Good morning and welcome to the Healthcare Affordability Board meeting. I will call the meeting to order and just thank you all for your participation today, both in the room and those online, particularly all things considered and going on. So just grateful to be in a space with all of you aligned on our overall mission of healthcare affordability across California. With that, I'll ask for the roll.
Good morning. Dr. Sandra Hernandez?
Present.
Secretary Kim Johnson?
Present.
Richard Cronick?
Present.
Ian Lewis?
Present.
Elizabeth Mitchell? Dr. Richard Pan? Don Molds? 4 present, 3 absent.
Thank you very much. And I will turn it over to Director Landsberg and Deputy Director Pagani for executive updates.
Thank you, Madam Chair, and good morning, everyone. Okay, having established a quorum and welcoming Don Molds, we will go ahead and go over the agenda. Your timing is perfect. So after executive updates, we have 3 substantive agenda items today. We will be going over our OCA baseline report. We'll be giving an update on the hospital measurement approach and then discussing the behavioral health definition and investment benchmark. In terms of executive updates, I'd like to wish everyone a happy Pride Month. I'm here showing off our Cal HHS Pride t-shirt, and the Secretary and I will be there with many HHS folks at the Sacramento Pride March, and I'm very proud to work for an agency that truly values all Californians, celebrates our diversity, and works toward equity. The team today will be presenting OCA's baseline report, which was published with the legislature and online last week. And I want to take a moment to acknowledge all that went into this baseline report. So the team's going to go over the substance, and I'd just like to give my thanks and acknowledge all that went into this. We have in California learned from other states. We've really dug into the available data. We have devised, revised, and revised again our data submission guide and our approach. We've, of course, gotten a lot of guidance here from all of you in the board about what was important to measure and how we should do that, as well as getting input from our many stakeholders about what was important to capture in trying to truly get as much as we could in understanding total healthcare expenditures in California. We've worked with the health plans to submit the data. So this was, anytime you're undergoing a new data submission request, there's a process. I'm proud at HCI about our stakeholder engagement approach. So my appreciation to the plans who gave us input, who tested the data, and all of whom submitted the data. Very, very proud of our data team who did this work building a new methodology. So glad that Vishal and CJ and Andrew will be able to present the work that they and their teams did on this. As would be expected with a complicated data project, there are certainly some challenges. How to capture data for dual eligibles is always a challenge, those who have both Medicare and Medi-Cal, and where to capture that. The many complicated Medi-Cal spending streams were 2 of the more complicated topics to address. It'll be really important to hear your input, and we'll continue to iterate as we learn. So I think this is a very solid first product, and I'm proud of it, and we know that it's important to get your input and to continue to improve the product as we go forward. So I wanted to let the board and the public know that HCI no longer has plans to move our headquarters to the Maile State Office Complex. So we will remain in this building at 2020 West El Camino, and therefore our ongoing board and advisory committee meetings will be held here. June 9th, very much on the top of minds for many of us, is the state budget. And so we didn't have a May meeting. I'm sure many of you were tracking the May revision to the budget and the $12 billion situation, that the $12 billion deficit that California finds itself in, that have necessitated some very difficult decisions, including in the healthcare space and around Medi-Cal. For HCI specifically, the revised budget has proposals that include $1.9 billion over 5 years to invest in the behavioral health workforce under the BH Connect waiver. BH Connect stands for the Behavioral Health Community-Based Organized Networks of Equitable Care and Treatment, quite a mouthful. So we're very pleased to be able to do this work on expanding and supporting the behavioral health workforce in California as part of the overall administration's behavioral health transformation efforts. The May revision also proposes requiring that pharmacy benefit managers, or PBMs, be licensed by the Department of Managed Healthcare and then provide data to HCI's HPD. We know there's significant concerns about prescription drug costs, really understanding the cost drivers. A lot of scrutiny has been paid to the PBMs, and so we're moving forward with discussions about the specifics of that PBM proposal. There's proposed trailer bill language and a BCP on Department of Finance's website. So we would receive some positions to support that oversight of PBMs to really gain a better understanding of their costs, with the ultimate goal of trying to improve affordability of prescription drugs in California. The May revision also proposes expanding the authority of CalRx to partner with brand name drug manufacturers. This change would give the state more tools to respond to supply chain disruptions, market manipulation, and other restrictions that could threaten access to essential medications, including those for reproductive health. So the CalRx program is proposed also to have $5 million available to respond to emergent pharmaceutical health needs. The revised budget also includes $90 million of Proposition 35 funds for HCI to administer for reproductive health investments for emergent needs, which could include midwifery, loan repayments and scholarships, and education capacity expansion for midwives. So that is the budget. Obviously, we're all waiting to see where the budget lands with the legislature over the next week. In other news on our healthcare payments database program, we're moving forward on collecting non-claims-based payments. So, you all know those are payments made that are not on a fee-for-service basis, including capitation payments and rebate information. So we're starting to collect that. We've put forward our regulations, and we'll be using a new national standard for collecting non-claims payment data. On the workforce side, we just announced last week, through 3 workforce programs, we recently distributed $38 million in awards to equip peer specialists and behavioral health professionals with the tools they need to deliver behavioral health services in California. So always lots more I could say, but with that, I'll turn it over to Deputy Director Vishal Pagani, who I'm just gonna do this. I will note just had his birthday yesterday, so happy birthday to Vishal.
Thank you, Director Lansford. So I'm going to go over a few articles first before diving into some other topics. The first is a recent health affairs article that found that hospitals investing more in capital infrastructure gained market share and raised prices, whereas hospitals investing relatively less in capital lost market share and increased their prices less. This pattern, the authors note, show that even in the absence of mergers and acquisitions, markets can consolidate as demand shifts to high-price hospitals. So the authors used a combination of health cost report information, or HCRIS reports, and commercial claims from the Healthcare Cost Institute. The authors explored the association between hospital capital expenditures, prices, and shifts in market share between 2010 and 2019. The researchers found that as hospitals increased capital expenditures, for example, through increased capacity, added service lines, and improved amenities, this supported entry into adjacent geographic markets that led to shifts in patient flow towards hospitals that invested heavily and away from rivals that invested less. This shift in demand translated into larger price increases at expanding hospitals, positioning these high-price hospitals for future expansion. Over time, these market dynamics contribute to a higher concentration of market shares and higher prices, both at investing hospitals and market-wide. So the slide shows a positive feedback loop about these hospital dynamics related to capital expenditures, which, the first is that profitable, higher price hospitals invest in capital relatively more than less profitable, lower price hospitals. This in turn results in these capital investments facilitating increased capacity, service line, and market expansions that shift patient flows to investing hospitals. The changes in volume of services delivered by investing hospitals enhance their bargaining power in negotiations with payers. And this enhanced bargaining power leads to larger price increases for hospitals with larger capital. And I'll take us to our next slide, which is another health affairs article about the Rhode Island affordability standards. So the authors evaluated the financial impact of Rhode Island's strategy to curb hospital prices and its effect on enrollee premiums and hospital margins in the commercial market. So beginning in 2010, Rhode Island capped hospital price growth in its fully insured commercial market as part of a set of reforms, which they referred to as the affordability standards. These standards include policies to regulate prices, including inflation caps and diagnostic-based payments on contracts between commercial insurers and hospitals and clinics, as well as investments in primary care. So the authors use a variety of data sources, including HCCI, or Healthcare Cost Institute hospital price data, CMS hospital cost reports, MEPS, or Medical Expenditure Panel survey data, among others. They found that across the fully insured and self-insured markets, hospital prices dropped by 9.1% on average between 2010 and 2022 relative to comparison states. And then the second observation was that fully insured premiums saw an average annual 449 relative price reduction. In terms of aggregate dollar amounts, the figures are listed here. That the affordability standards were associated with a reduction of $87.7 million in annual premium and out-of-pocket spending for the fully insured market, an increase of $30.7 million for annual spending for the self-insured market, and a reduction of $158.3 million in annual hospital commercial revenue. The authors conclude that evidence from their study suggests that Rhode Island's affordability standards reduced hospital prices and resulted in lower insurance premiums and out-of-pocket spending in the fully insured market segment. However, premium reductions were not observed in Rhode Island's self-insured market, and they called for greater transparency and oversight may be required so that these set of reforms benefit the self-insured market segment. And I'll take us to our next slide. So at our last meeting, Board Member Pan requested an update on the economic indicators that were used to set the statewide spending target. So OCA reviewed 2023 data on key economic indicators to assess whether the spending target, which was based on a 20-year look back between 2002 to 2022, remains appropriate. In 2023, median household income increased 5.4%, bringing the 20-year average to 3.1%. That's a modest increase of 0.1 percentage points over the prior 20-year period. And then we included other changes in other metrics for which there's data. The Consumer Price Index, or CPI, rose 3.6% last year. This kept the 20-year average at 2.8, with no change compared to the previous 20-year average. Another economic index, the Medicare Economic Index, which tracks inflation for physician services, rose 3.8% in 2023. that nudged its 20-year average up to 1.7%, which is also equates to a 0.1 percentage point increase. So given the modest changes in long-term averages, these updated figures continue to support the 3% spending target as a reasonable and appropriate benchmark. And I'll take us to our next slide. So on this slide, I wanted to discuss a payment to cost ratio coding correction. This was one of the measures that's used to identify high cost hospitals in OCA's methodology that we presented earlier this spring. So the payment to cost ratios, it's that commercial to Medicare relative price ratio was originally calculated using Python code. In mid-May, OCA staff created Stata code, which is a different software to calculate payment to cost ratios, and found that the resulting output differed from those that had previously been shared publicly. We investigated the source of this discrepancy. We noticed that of the 75 hospital revenue centers referenced in HCAI's, hospital annual financial disclosure reports, one revenue center, therapeutic radiology, was inconsistently included in the original Python code. OCA staff and consultants met on May 21st to confirm the initial oversight. Upon recalculating the payment to cost ratios for comparable hospitals for the years 2018 to 2022, including all 75 revenue centers, OCA found that the set of hospitals deemed high cost did not change, nor did the proposed sector target value for those high cost hospitals. So we've updated our website to include an updated hospital level data set, which is on our data and reports page. We've included additional slides in the appendix to show how previously reported payment to cost ratios differed from the updated payment to cost ratios based on a full accounting of all hospital revenue centers. So I do want to pause here before I provide other updates, just so if any board members have any questions before I go on. So now I wanted to spend some time providing updates on pharmaceuticals and affordability. I'll start by providing some background information on pharmaceutical costs and their impact on overall spending. This chart shows the rapid growth in retail prescription drug costs over the last few decades. They have two curves. One is inflation adjusted and one is in nominal dollars. It's a trend going from 1960 to the 2020s. So this is focused on retail prescription drugs, which do not include drugs that are physician administered in hospitals, doctors' offices, outpatient centers, other facilities like long-term care. The figure shows that spending on retail prescription drugs has increased since 1960, with growth accelerating significantly in the 1990s. Adjusted for inflation, retail prescription drug spending per capita in the U.S. increased from about $100 in 1960 to a little over $1,100 in 2021. Some of the factors impacting growth in drug spending include unit prices and changes in utilization patterns, especially with the market entry of new high-cost drugs. So many of you are aware of the GLP-1s. There's also very expensive cell and gene therapies. Some growth is also caused by excessive profit-seeking and anti-competitive behavior across different actors in the prescription drug market. And then I'll take us to our next slide. So at the same time that prescription drugs are a cost driver, they can also serve as a moderator of costs because they help people manage the conditions they have, such as patients that take SSRIs for treating depression, Prescription drugs can also be used to mitigate the risk of developing conditions such as statins to lower cholesterol and reduce the risk of heart disease. However, the high cost of certain drugs pose a barrier to medication adherence. There's some information from a Kaiser Family Foundation survey that about 3 in 10 adults report not taking their medicines as prescribed at some point in the past year due to cost. This includes about 1 in 5 who say they have not filled a prescription or took an over-the-counter drug instead. And 12% who say they cut pills in half or skipped a dose because of cost. On the same slide, there's a figure to the right discussing the impact of poor medication adherence on health outcomes, but also increased costs for the patient and the system. Poor medication adherence leads to increased utilization, which some have estimated to add additional costs of thousands of dollars per member per year. And then going on to the next slide. So as many of you know, there's a complex distribution system for pharmaceuticals with several actors between the production of a drug and the drug getting to a patient. Manufacturers sell drugs to pharmacies through contracts with drug wholesalers, and pharmacies in turn dispense drugs to the patients. When pharmacies do so, they run the claim through an administrative process involving pharmacy benefit managers. These entities tell the pharmacies how much the patient should pay for the drug, and they collect and pass through reimbursement to the pharmacy from health plans. The 5 entities shown here, manufacturers, wholesalers, pharmacies, PBMs, and third-party payers or health plans, each play a role. Of note, the lack of transparency and multiple steps in this system mean there's ample opportunities for markups, excessive profit-seeking, and misaligned incentives that lead to increases in overall drug costs. One example is PBMs, which decide what drugs are prioritized on a health plan's formulary in exchange for price concessions or rebates from manufacturers. PBMs argue this leads to lower overall costs, but others say that the rebates can lead to the preferential selection of higher cost drugs so that more rebates are retained by the PBM and or health plan. I'll take us to the next slide. I know this slide is very busy, but I'll try to walk us through it. So what else increases costs? Let's go through the list. There's research and development costs, and it typically takes about 12 years to move from preclinical testing to final approval. Some estimates are that it takes $3 billion to develop a new drug, with only 10 to 20% of drugs tested being successful in reaching market. While these R&D costs are staggering, some studies have found no connection between how much drug companies spend and the drug's price. There's rebates, as I just discussed. There's also lack of transparency in contracts across the system, making it difficult to see where money flows. PBMs are increasingly arguing that they are passing on 100% of rebates, but then appear to be retaining profit from manufacturers through other administrative fees. There's also spread pricing, where a PBM reimburses a pharmacy less than what they get from reimburses a pharmacy less than what the PBM gets from a health plan or for a drug. There's also substantial concentration with 3 PBMs and 3 wholesalers dominating the market. As the chart shows, there's substantial vertical integration between many insurers, PBMs, group purchasing organizations, manufacturers, and pharmacies. Some have even described PBMs as a profit center for some vertically integrated health plans. On the pharmaceutical manufacturer side, there are also practices that are leading to reduced competition, such as product hopping, where minimal changes are made to a medication and patients then switch to the updated version. There's patent thickets, where multiple patents on drugs deter other competitors from entering the market. and others that are listed here. And then lastly, as I mentioned earlier, increased utilization and introduction of new high-cost drugs also leads to increased spending. We hear a lot about GLP-1s and how they're increasingly consuming a share of healthcare spending. Cell and gene therapies also cost, in the millions of dollars per application because they have to be tailored to specific individuals. So with that, I'll take us to our next set of slides before opening to board discussion, which is how's OCA responding, or HCI, as an enterprise responding to some of these issues. So I'll start with some of the references to pharmaceuticals in the OCA statute. So there's language pertaining to analyzing costs and quality trends in the pharmaceutical sector, studying how drug prices and pharmaceutical market failures impact affordability, and informing public policies to improve competition and lower costs. Our total healthcare expenditures definitions includes pharmaceutical costs. And then when we turn to cost driver analysis, the board will also discuss drivers in the pharmaceutical sector. Taking us to the next slide, the statute also calls out using SB 17 data, which I'll discuss shortly, and the healthcare payments data in analyses. And there's also requirements on us to not disclose any proprietary or confidential information in our reporting. Next slide. There's also OCA's Cost and Market Impact Review Program. The implementing regulations also require PBMs to file advance notice of material change transactions if they meet certain thresholds. OCA also has broad authority to conduct research on the healthcare market. And then moving on to the next slide. Taking that in stock, there's essentially two large buckets of pharmaceutical policy work in OCA. We're currently building analytical staff capacity for policy research and analysis. So the first one is you're already familiar with, which is identifying and reporting on spending trends and drivers. We're also considering how drug costs could be considered as a reasonable factor for exceeding the spending target. We've started engagement with healthcare entities, including plans, hospitals, and physician organizations, to learn more about the impact of high drug costs and how OCA should consider them as part of progressive enforcement. The other bucket of work on the right is related to general research and analysis. So some of this work supports other state efforts for improving access and affordability, such as through CalRx. Some of it also involves reviewing best practices in other states and how we could replicate those ideas here. And then other work is going to involve policy recommendations in our annual reports, so that state policy is informed by data, and we include recommendations on potential actions that could be taken. And then going on to the next slide. We include a list of data sources here. Some of them I'll walk through in the next set of slides. I do want to focus on, as the director mentioned, there's a May revision PBM reform proposal. This would add data to the HPD. PBMs would directly report data, so OCA would have additional data at its fingertips for analyzing the market and informing public policies. Next slide. So this is a slide about our HCI-administered CalRx program, which focuses on state partnerships resulting in the production, procurement, or distribution of generic drugs and making them available at low cost. This program targets areas where the system has failed to lower costs, even when a generic or biosimilar is available. And then taking us to the next slide. So this is an example of how we're using data to support our CalRx program. So we used HPD data, census data, and pharmacy location data from the Board of Pharmacy. to create a visualization map to identify hotspots where there's a high degree or high prevalence of diabetes and potentially reduce access to pharmacies, so that as Civica and CalRx work together to distribute the products once they're available, we'll be able to troubleshoot any potential gaps, strategize on alternative distribution methods, including partnering with local organizations and looking into direct-to-consumer or mail order options. Next slide. So outside of CalRx and OCA, HCI also has responsibilities for SB 17, which was signed into law in 2017. So there's a 60-day advance notice about wholesale acquisition cost increases above 16% over the past 3 years. Wholesale acquisition cost, or WAC, is referred to as the list or sticker price from the manufacturer. There's another requirement that manufacturers submit new drugs introduced to the market with a WAC that exceeds the threshold set for a specialty drug under the Medicare Part D program, which is $950 per month per course of treatment as of January 2024. So in addition to reporting, collecting and reporting on SB 17 data, we also provide interactive visualizations. So there's essentially 3 categories. One is a cumulative look back, one is a current year WAC price increase visualization, and then the third is related to new drugs that exceed a certain Medicare Part D threshold. And then taking us to our last slide. So we collect claims data for prescription drug spending through the HPD. HCI put out its first report on fee-for-service drug costs in the commercial market. We looked at monthly median out-of-pocket costs for the 25 drugs with the highest out-of-pocket in the commercial market. This provided us insights into consumer affordability. The figures that are shown on the slide, are evaluated within the context of state policies that have limited the monthly maximum out-of-pocket cost to $250 per script as kind of a limit on consumer cost sharing, and we're seeing this bear out in the data that the monthly median out-of-pocket costs are below the state limitation on monthly per script amounts. And then later this year, HPD will begin collecting pharmacy rebate information from payers as part of its non-claims data collection. And then I'll take us to the very last slide. We remind everyone, including the board and the public, about our slide formatting. Yellow denotes areas that are informational items for board discussion, but decision authority lies with OCA, and then green arrows indicate areas for which the board has ultimate decision-making authority. So I know I covered a lot in my executive updates, and I'm happy to turn it over to the chair to facilitate discussion.
Thank you very much. Appreciate that. A few different topics in those updates that you covered. Just before I turn it over to other board members, anything that you'd want to highlight for the board and public about some of the federal changes in the same space around prescription drugs? Anything you'd want to highlight for?
Yes, we've, there was an executive order from the Trump administration. We're still evaluating it. There's some changes to accelerate the approval of new drugs to the market. There's a few others that are similar to the first Trump administration. So we're in a kind of monitoring phase to see how those policies ultimately bear out.
And I would just add that as it relates to the PBM proposal, we're also looking at the federal definition and language used in that space.
Questions from the board?
Thanks. Great report. I'm curious, the payment to cost ratio coding correction, how did that come to your attention? A, and B, I appreciate your transparency with the public on rerunning the numbers, but I'm curious how that was caught.
Yeah, so it came to our attention because we were developing the code using Stata, because we're preparing to redo the analysis when we have future years worth of data, and most of our shop internally uses Stata as their preferred coding language. And so when we had done that in Stata and then replicated the analysis on the existing data sets, we noticed that there was some small discrepancies in the values, and that's when we met internally and with our external consultants to confirm the initial oversight of the therapeutic radiology cost center being inconsistently applied and considered in the Python code that we had initially used to develop the outputs.
I just really appreciate the transparency in that and rerunning the numbers, so thank you for doing that.
And just to say, the error was initially made by a contractor. We've talked to them about their quality control, and we're also looking internally at our quality control. But I agree, really appreciate the team's transparency, raising it to legal right away, mute right away, and we elevated to the secretary.
Likewise, I appreciate the transparency, and I know firsthand just how hard it can be to wrangle messy data. On the prescription drugs, I think I'm aware generally that there are complicated antitrust issues on the one hand and federal preemption issues on the other hand that hamstring our state's ability to make bolder interventions. But I'm wondering, I know the state's doing some good work to align CalPERS and Medi-Cal and so forth. I'm just wondering if there's been any discussion in those spaces about whether there is space or interest in exploring space to align private purchasers and especially payers around a common formulary or other things that extend the reach of that initiative.
You could go. Yeah.
So there, and you're going to remember the history of this better than I am because I'm trying to conjure it up right now. But there was in the early days of the first Newsom term, there was a group that was put together that was a coalition of public purchasers to talk about this, and I think CalRx was part of that movement. There have been efforts coming out of, it's too bad Elizabeth isn't here, Purchaser Business Group on Health, to try to address a number of these issues. So to bring together there are a number of the public purchasers are part of that group. They support common legislation at the federal level. So that's been another effort. The big challenge on the drug side is that almost all of the none of the PBMs to date that I'm aware of offer insured products. So they're all self-insured products, partially because there's not a ton of interest in having a lot of exposure to potential losses in that space. So state law has been pretty limited in its effect on PBM. So that is different when a health plan is rolling up and offering a single insured product. But for us, for example, our PBM spend is entirely self-insured and not subject to state law, which is created. You want to? I'm sure there are lots more details about the group that was put together. To my understanding, it's not been meeting for some time now on drugs. Maybe I'm missing something.
Yeah, I don't have the latest information, but there was an early effort to do bulk purchasing among the public purchasers, so DGS. It included CalPERS and covered California. It did lead to some, an outgrowth of that was some contracting with UC and kind of, which did lead to some savings using kind of the, DGS's ability to contract. Yeah, but kind of, as we mentioned earlier, the PBM licensure and data collection, kind of that's the more active proposal on in the drug space.
Yeah, I think also the big challenge on bringing the public purchasers together is Medi-Cal and the arcane rebate rules and Medicaid, which make it extraordinarily difficult to do that. They're also the purchasers on the state side are very different. So covered California is entirely insured products, for example. The prison system is got its own thing. We have our self-insured PBM. We purchase an insured product from Kaiser that rolls up drugs because they've been very effective at keeping prices as low as anybody. So it's hard to wrangle everybody together on this one.
Thank you. I second or third the comments of my colleagues. Thank you for bringing the error in the payment to cost ratios to our attention. Just one comment going back to slide 10, the first slide that you presented, Vishal. Drug pricing is certainly a mess and a scandal, and the fact that we pay 2 to 3 times what folks in Europe pay for the same drug is like, why do we do this? Because we don't have any system of paying less, and working on trying to fix that makes a lot of sense. But just looking at, this comment is in part a response to some of the comments made in public comments. Why did we spend so much effort on identifying high-cost hospitals and not doing the broader work of understanding cost drivers throughout the system? I think that this slide well illustrates part of the answer to that, which is, as you pointed out, Vishal, drug prices have gone up a lot more than everything else over the last 60 years. But over the last 15 years, from 2005 to 2020, this is not such a terrible story. And again, with GLP-1s, it's going to get worse, and we need to be paying attention. And I'm not suggesting we shouldn't be paying attention, but not the big cost driver of why have healthcare costs been increasing so much, at least from the 15 years from 2005 to 2020. And we ought to keep that perspective, I think, as we go forward.
Thank you. Thank you, board members, for that discussion and again for the presentation. We'll open it up for public comment on the executive updates.
We will now recognize members of the public for comment on this agenda item. Please reserve comments on other items for the general public comment period. To ensure equitable access to verbal public comment, we will alternate between members of the public present in this room and those attending virtually. Those in the room may line up at the podium. Those attending virtually should click the raised hand button. Those dialing in can press *5 to raise your hand. It will track the order in which the hands are raised. During the public comment period, you will be unmuted when it is your turn. We also invite you to provide written comments at the email address on today's agenda. Please keep your comments to 2 minutes or less so we can hear from as many members of the public as possible. Please note that while the board is committed to communication and transparency, board members and staff will not be responding to public comment. Additionally, the board may not discuss or act on any matter raised during the public comment period that is not already included on the meeting agenda, except to place the matter on a future meeting agenda. I will start with the individual at the podium. Please go ahead.
Beth Capel for Health Access. We too appreciate the transparency on the PTCR and note that the therapeutic radiology is, we would guess, a probably very small source of revenue to hospitals, maybe under 1%, but we would defer to staff who actually know. So it's good to be transparent, it's good to be accurate, but it probably didn't make a difference in the results. So we appreciate knowing all of that. We are very encouraged by the health affairs piece on Rhode Island and the experience in Rhode Island and actually translating this into better affordability for consumers. And it's part of what's encouraged us to do this work. We appreciate the overview on prescription drugs. We would note where Vishal began that it only discusses retail prescription drugs, and a lot of what you've heard in public comment from others is about prescription drugs administered in hospitals or doctors' offices or hospital outpatient departments. And those are places where the entities in question arguably have some control over how much they charge and how much they pay for those drugs. We would also point out that because of the merger of PBMs with insurers, that arguably health plans have some control. If PBMs are actually doing their job, we would hope that health plans have some control over negotiating lower prescription drug prices, although we'll see whether it actually matters or not. So we look forward to more discussion on prescription drugs as we move forward. Thank you.
Thank you. Looking virtually, seeing no hands raised with roughly 92 virtual attendees, we'll go back to the podium.
Good morning, OCAW board members and executive staff. My name is David Lai, and I'm commenting on behalf of California Life Sciences. CLS represents over 1,300 organizations in the life sciences community, including pharmaceutical, biotechnology, medical technology, and academic research institutions. All of our members are committed to advancing innovation and improving health outcomes across California. Our mission is to facilitate a favorable environment for the life sciences to flourish in California and to continue leading the nation and the world in delivering innovative solutions to address the most pressing global health needs. California's life sciences members, we forge an outsized impact on clinical trials, on breakthrough medicines and treatments. We therefore have a vested interest in working with our state's policymakers to establish an innovation environment that enables this dynamic ecosystem to benefit patients worldwide. We appreciate Deputy Director Pagani's brief on the work of OCAW staff in the pharmaceutical segment of the healthcare ecosystem. As OCAW staff continues to take a data-driven approach to identify and address strategies for drug access and affordability issues in the state, CLS wants to be a go-to resource for the agency to provide the most fulsome understanding of the pharmaceutical field. As slide 12 illustrated, the pharmaceutical distribution and payment system is quite complex, with several players having critical roles in the pharmaceutical value chain, from the research and development of life-saving and life-sustaining products, our members, to patient access to these products. We do look forward to having productive discussions with staff. Thank you.
Thank you. Looking virtually, seeing no hands raised, back to the podium.
Good morning, Ben Johnson with the California Hospital Association. California's hospitals reiterate our deep disappointment in last month's decision on the hospital sector targets that ultimately fail to account for really what it takes to provide high quality care, particularly in this current unstable economic, political, and policy environment. And as a result of decisions here in Sacramento as well as Washington, D.C., patients will lose access to care, jobs will be lost, and hospitals are at risk of closure. Today's executive update adds to hospitals' concerns with OCA's approach to date. First, OCA summarizes the study from Health Affairs, really criticizing the fact that hospitals that make investments in, quote, capacity, services, and amenities see more patients and have prices that reflect the cost of these investments. And highlighting this study calls into question whether we think OCA appropriately values efforts to attract patients through improvements in care delivery, expansions of services, for example, to keep up with the aging population and their needs. Second, OCA provided an update on macroeconomic indicators like inflation, household income growth, but did not offer policy changes to account for the elevated trends now being experienced. And providers cannot plan based on inflation from 20 years ago. They plan for current and expected future economic conditions and healthcare needs, and OCA should do the same. Third, and finally, it is very concerning that 6 weeks after making decisions based on hospital spending data, OCA has identified errors in its methodology for determining which hospitals are high cost and their corresponding target values. CHA shared at the time that we could not replicate OCA's data, and we still can't. And this reflects just one of the errors that have been identified so far in OCA's data. And rushing forward with this decision and checking the work after the fact does not reflect a sound process, and evidences a clear need to revisit OCA's decisions and exercise significantly more due diligence going forward. Thank you.
Looking virtually, seeing no hands raised. Going back to the podium. Seeing no one at the podium, that concludes public comment on this item.
Thank you very much. We will move on to item 3, the approval of the meeting minutes as a consent item. Deputy Director Bergani?
So we just have the April meeting minutes. They've been distributed along with the public comments received since the last meeting.
Is there a motion to approve? Second?
Second.
Thank you. And we will invite public comment.
We'll now take public comment on this item. Please step to the podium or raise your hand virtually. Please limit your comments to 2 minutes.
Beth Capel on behalf of Health Access. We are pleased with the action that the board took last month to identify high-cost hospitals. We would note that this is the first, and which are reflected in the minutes that you are voting on. This is the first state to figure out how to identify the hospitals and other entities that have start from a very high cost base and attempt to address it. So we think it was an important action, and we appreciate the minutes that reflect that. Thank you.
Thank you. Looking virtually, seeing no hands raised and no one at the podium, that concludes public comment on this item.
Thank you. And can we please call the roll?
Dr. Sandra Hernandez?
I was not at the meeting, so I will abstain, but not because I disagree with any of the action that was taken.
Thank you. Secretary Kim Johnson?
Aye.
Richard Kroenig?
Aye.
Ian Lewis?
Aye.
Elizabeth Mitchell? Dr. Richard Pan? And 3 ayes, 1 abstain, 2 absent.
Thank you. We will move on to item 4. These are informational items for this meeting, and start with the presentation of the baseline report, a group presentation here by Vishal C.J. Howard, the Assistant Deputy Director of Healthcare Spending, as well as Andrew Fair.
All right, thank you. I will kick this off. I want to start with sharing my gratitude and acknowledging the monumental team effort that this was. I really wish that we could have one member of staff come up and present each slide so that they could take in celebrating this moment for OCA. But with that, you'll just have to deal with Vishal, Andrew, and myself, and we'll go from there. I also want to thank the commercial and the Medicare Advantage plans for their continued support and collaboration in this inaugural effort. Really, I think we fostered collaborative and truly meaningful working relationships to to pull this together in relatively short order. So right now I'll turn to some background on the data collection and engagement. So starting in September, OCA facilitated multiple technical work groups. This included developing the specs for how data would be collected, and then ultimately with work groups for how the data would be submitted. We addressed reporting questions, we clarified specifications, and we provided technical assistance throughout the submission process. Through the summer of 2024, OCA accepted and reviewed test submissions in advance of the formal submission window to ensure system readiness and to troubleshoot data formatting issues. In the fall and summer of 2024, OCA performed data validation and engaged directly with submitters to resolve discrepancies, clarify anomalies, and support resubmissions as needed. In November and December, OCA held individual payer preview meetings with all data submission guide submitters. That is, those entities who submitted commercial and Medicare Advantage data, to review preliminary results and ensure accuracy and provide transparency regarding how their data would be reflected in the final report. For Medi-Cal spending, OCA has actively collaborated with the Department of Healthcare Services to collect, review, and validate managed care organization data submitted through the state's medical loss ratio template. OCA also collected commercial market total medical expense directly from the payers, but not comprehensive administrative cost and profits data. For the commercial fully insured market, OCA collected administrative costs and profit amounts from CMS Centers for Consumer Information and Insurance Oversight, or CISIO, medical loss ratio data. A few submitters also voluntarily reported administrative cost and profits data for self-insured commercial plans. In the baseline report, we note that commercial administrative cost and profit spending is understated due to incomplete reporting. For the Medicare Advantage market, OCA used two data sources to calculate administrative costs and profits. For large insurers, OCA used the medical loss ratio data collected by CISIO. For small Medicare Advantage payers who are not required to submit data to CISIO, OCA used data from plans' annual financial filings with the Department of Managed Healthcare. You can go to the next slide. This graphic just provides a reminder of how OCA defines the total healthcare expenditures as composed of total medical expense, or TME, which includes claims payments, non-claims payments, and member cost sharing, plus health plan administrative costs and profits. These components form the foundation of OCA's baseline report and spending target monitoring program. Next slide. The report presents results at both a statewide and market levels as shown here. Each major market, Medi-Cal is orange, Medicare is purple, commercial is green, and other is gray. It is color-coded, further broken out by coverage type to reflect how data are analyzed and reported. Just a reminder, so we are reporting on 22 and 23 spend. Next year is an optional report, not called for in statute, but to get reps under our belt, we'll be issuing sort of a baseline +1, which will have 23 and 24 data. And with that, I will hand it over to Vishal for a high-level overview and substance of the report.
So this slide captures a few of the more aggregated figures presented in the report and gives us a first glimpse of an estimate of total statewide spending in California from 2022 to 2023. Our next report will feature spending and growth from 23 to 2024. So first I'll start with changes in total healthcare expenditure. So this is healthcare spending, including health plan administrative costs and profits. So between 2022 and 2023, THCE changed as follows for the three major markets. Commercial spending grew 5.8%. Medicare, this is just focused on non-duals, spending grew 6%, and Medi-Cal spending grew 6.5%. So this figure that I'm mentioning is in aggregate kind of dollar amount change. And then now I'll shift to a per member per year spending figure. So for THCE per member per year, for Medi-Cal and Medicare, inclusive of duals, averaged 2.9% and 5.4% respectively. while commercial spending per member per year was 6.4%. So when we aggregate this market level spending, for these three major markets with other state and federal healthcare spending, statewide THCE totaled $377.6 billion in 2022 and $408.6 billion in 2023, an increase of $31 billion or 8.2%. When we take this figure on a per capita basis, that is, we take total healthcare expenditures and divide by California's population, THCE per capita was roughly 9,676 in 2022 and 10,847 in 2023, an increase of $811 or 8.4%. So moving on to changes in TME. So this is healthcare spending excluding health plan administrative costs and profits. Growth in spending varied across markets, payers, regions, and service categories between 2022 and 2023. TME, or total medical expense per member per year, growth among Medi-Cal and Medicare markets averaged 1.2% and 6.1% respectively, compared with an average of 5% for commercial. I'll take us to our next slide. So this slide provides some context for OCA's work and shows how various key consumer affordability measures have been outpacing growth in household incomes. So over the past 20 years, the financial burden on California workers with private coverage, driven by rising deductibles and their share of premiums, has grown faster than total premiums and median household income, highlighting a persistent affordability challenge. And then taking us to our next slide. So this is just another visual of what I communicated earlier, which is on an aggregate basis, there was an 8.2% change on total healthcare expenditures, which translates to an 8.4% per capita change. And then going on to the next slide. So this is drilling down into more kind of, what is the share of spending by market? Commercial spending was roughly $121 billion in 2022 and $128 billion in 2023. This was an increase of $6.9 billion or 5.8%, and it captured about 31% of the 2023 statewide total healthcare expenditure value. Medicare, excluding duals, spending was $106.3 billion in 2022 and $112.6 billion in 2023. So this was an increase of about 6%. In 2023, its share represented about 28% of statewide THCE. Medi-Cal spending, increased from $125.9 billion in 2022 to $134.1 billion in 2023, an increase of about $8 billion or 6.5%. And its share was just below a third or 33% of statewide THCE. So we include duals in Medicare Advantage plans and DSNPs, which is dual eligible special needs plans. This spending represented about 2% of statewide THCE, but its spending grew more than 35% from $6.5 billion to $8.8 billion, an increase of about $2.3 billion. Before I move on, I do want to flag that we do have an other category, a spending which we do note that there's a large jump of approximately $7.2 billion in the other category, or 40%. So there still is some spending, and the report calls this out, that this other bucket does include other Medi-Cal and non-Medi-Cal program spending. The other Medi-Cal spending includes dental and IHSS. The non-Medi-Cal spending includes the kind of the niche programs like the breast and cervical cancer treatment programs, GHPP, which handicap, yeah, genetically handicapped persons program. So we're still working closely we'll work with DHCS in the future to better tease out these funding streams because we do think some of these dollars should be more appropriately bucketed with the larger Medi-Cal program spending. It was just complicated to tease that out because of many factors, including calendar year versus fiscal year reporting, cash versus accrual-based accounting. And there's also some time lags associated with how some of these payments are made. And then I'll hand it over to Andrew to walk through some of the more detailed breakouts.
Thanks, Vishal. So many of these exhibits are going to look very familiar to those you saw earlier in the year. Just now we'll actually have the actuals behind them. So with this slide here, we're going to show total healthcare expenditures on a per member per year basis by those major market categories. And so going from left to right, starting with the commercial market, THC per member per year was just under $7,000 in 2022 and increased to just over $7,400 in 2023, which represents a relative increase of 6.4% and an absolute increase of $443. For the Medicare market, here we're going to be including those duals and D-SNPs, which I mentioned earlier. THC per member per year was about $17,900 in 2022 and increased to $18,851 in 2023, an absolute increase of $972 and a relative increase of 5.4%. And finally, rounding out these major market categories, Medi-Cal THC per member per year was $8,343 in 2022 and increased to just under $8,600 in 2023, an absolute increase of $243 and a relative increase of 2.9%. Next slide, please. So shifting now to total medical expense, where we strip away the administrative costs and profits. This slide similarly is going to show those PMPYs in dollars and their respective growth rates by those three major markets. So TME per member per year for the commercial market was just over $6,500 in 2022 and increased to $6,829 in 2023, an absolute increase of $326 or a relative increase of 5.0%. For Medicare, once again, including duals and D-SNPs, those data points were $17,437 in 2022, increasing to just over $18,500 in 2023, an increase of $1,064 or 6.1% on a relative basis. And then finally, Medi-Cal TME per member per year, and this again is pooling both managed care and fee-for-service spending, was $7,926 in 2022 and increasing to a little over $8,000 in 2023, an increase of $95 or 1.2%. We can go to the next slide. So here you saw this slide without numbers early in the spring. This is where we present payer level total medical expense growth rates as well as their respective enrollment shares. And so OCA collected data from commercial and MA plans, and for the commercial market in particular, that approximates about 17.2 million Californians with commercial coverage in 2023. And you'll see the largest plan is Kaiser there, which accounts for just over 41% of covered commercial lives, followed by Blue Shield's 15.6%, Anthem Blue Cross or Elevance at 14.3%. Together, those plans make up a little over 70% of the reported commercial enrollment. So as shown on that prior slide, total commercial TME per member per year was a little over $6,500 in 2022 and rose to about $6,800 in 2023, representing an increase of 5%. But as you can see on these sort of cake pop diagrams we have here, the growth rates in TME did vary quite a bit. You see a slight decrease of 0.02%, upwards to a 20% increase for payer, but most payers saw growth rates between 4 and 6% in the commercial market. So I'll note, as part of OCA's payer previews that CJ mentioned with data submission guide submitters, we presented these unadjusted TME per member per year growth rates in November and December to payers. But as we noted in the baseline report, OCA also computed demographically adjusted total medical expense per member per year amounts, and will include those outcomes in a forthcoming data book. So you can see how adjusted growth rates compare to the unadjusted growth rates in the baseline report. And so those that data book is expected to be out later this month. We can move on to the next slide, where we'll feature Medicare Advantage payer level TME growth rates. So OCA collected MA data that captured about 2.6 million Californians enrolled in Medicare Advantage plans. Kaiser had about 48.5% of those enrollees, followed by United at just under 18%, and then SCAN with about 9.4% of the enrollment. And together, those plans represented about 76% of the reported Medicare Advantage enrollment in 2023. Here, too, we do see pretty substantial variation in total medical expense growth rates. So while overall the growth rates were about 3.6% from 2022 to 2023, there were decreases on the order of 12% and increases on the order of about 11% from 22 to 23. And the next slide will round out with the Medicare managed care market. So here, substantially more payers, about 23 payers in the MCO space. 4 of those payers, LA Care, Centene, Inland Empire, and Anthem, accounted for a little over 50% of total MCO enrollment. And Medi-Cal managed care payers saw an average TME per member per year increase of about 5.5% between 2022 and 2023. Here again, growth rates vary quite substantially, with some experiencing increases of 15 or more percent in TME growth, while others saw decreases. And we do note in the baseline report some of this variation in TME growth may reflect statewide policy changes, including shifts in how DHCS administered covered benefits from one year to the next. Next slide, please. So OCA also, as part of its data collection, gets spending category level or service category level data from commercial and Medicare Advantage plans, as well as through a data request with the Centers for Medicare and Medicaid Services, obtains Medicare fee-for-service claims amounts. And so in this particular case, we're going to be reporting both the statewide, so those pooled categories, as well as broken out for commercial and the Medicare markets. So you can see both the MA as well as the Medicare fee-for-service markets. So that first column shows statewide total medical expense per member per year increasing 6.2% from 2022 to 2023. Retail pharmacy at 12%, professional services at 7.6%, and capitation at 7% had the highest growth rates among those respective service categories. Then the largest dollar contributors to that total statewide per member per year growth were retail pharmacy, capitation, and hospital outpatient services. All right, we can move on to the next slide. So we're just going to provide some data points with each of those respective market categories. So in the commercial market, again, I feel like we've noted this a few times now. Commercial TME per member per year increased by 5% or $326. When we sort of seek to unearth the underlying drivers, retail pharmacy contributed $117 or 36% of that growth. Hospital outpatient spending contributed about $94 or about 29% of that growth from 22 to 23. Within the Medicare Advantage market, total medical expense per member per year grew by 3.6%. Retail pharmacy contributed about 42% of that growth, whereas capitation contributed about 37% of that growth. And then finally, for Medicare fee-for-service data, for which we only have claim spending, we do not obtain non-claims expenditures as part of our data exchange with CMS. So claim spending per member per year grew from $18,924 to $20,301, an increase of just under $1,400 or 7.3%. Retail pharmacy here again contributed $410 or 30% of that growth, and then professional services contributed $379 or 28% of that growth. Home stretch here, digging into regional spending trends. And so just so for background, the regional data OCA collects is limited to claims and capitation spending from those data submission guide submitters, so commercial Medicare Advantage markets, as well as dual eligible members and members in D-SNP plans. And that spending is assigned to regions based on a member's address. And so by virtue of the fact that non-claims payments are typically lump sum payments for medical care and not necessarily attributed to specific members, we don't have that non-claim spending broken out by region. So this is just going to be claims and capitation spending. And so these figures on the left and right show both the 2023 per member per year spending levels on the left, as well as their respective growth rates from 22 to 23 on the right. And we think the comparison helps illustrate that regions with the highest baseline spending aren't necessarily always those that are going to be the fastest growing year over year in their spending trends. But it does tell a similar story to what we've seen with other sources, namely that spending tends to be higher on average in Northern California and lower in Southern California, though we would note, as you see in the baseline report, there are some select service planning areas within LA County that do exhibit high spending. And with that, I think we can open it up for any questions or comments.
Thank you. Questions from the board?
Thank you, Andrew. You were talking about the Medi-Cal managed care baseline report data, and you were talking about different timing and timelines for the data. Can you just elaborate on the complexities of that?
Sure. Yeah. So as part of OCA's data collection, commercial and Medicare Advantage data comes in the fall. So between September, I think due to some resubmissions, it's a new template. So it took a couple of passes for a few submitters, but for the most part, we had all commercial and Medicare Advantage data, I want to say by November-ish, whereas by virtue of the fact that we have a data exchange we don't currently have a feed directly from the managed care plans. We rely on DHCS through the MLR reports, and so those don't get finalized. The deadline for submission is until December 31st of the calendar year. Those don't start flowing to DHCS. I think the last one came through in mid-March, but we had a really, I think, effective partnership with DHCS. So as soon as those enter their sort of SharePoint folders or their sort of shared drives, they pass those right along to us. So just a little bit of a lag in when we could process the commercial and MA data versus sort of a little bit more of a wait on getting the Medi-Cal managed care organization level data.
Is there a vision for being able to get that data directly from the plans?
Yeah, we've to reduce administrative burden, and we have given a temporary, essentially kind of a delay for MCOs to directly report data to us. So that's been in place for the first two reporting cycles. They didn't do it for this baseline report. They won't do it. The THCE files for next year. They are going to report the new files we have for alternative payment models in primary care. That is going to be a direct submission from MCOs. And then as we build out the program, we'll likely need to get direct data collection from MCOs, especially to do the provider level reporting to physician organizations. Only they could do the attribution because they're aware of kind of those relationships.
First, congratulations and thank you. I can only imagine the work needed to have a whole new data stream and turn it around into this report, and very impressed. Having said that, as we've discussed, you brought up the treatment of dual eligibles, which I think is problematic. It makes it kind of harder to interpret, and including dual eligibles and the D-SNPs in all of the Medicare reporting in the future, I think would make a lot of sense. As you get the time to catch your breath a little bit, comparing the results here to other results would be helpful, I think, for the public and for us to understand relative to kind of other estimates of what total health expenditures look like in California, kind of what do these numbers look like? It doesn't mean that the other estimates are gold standards. You probably have better data here, but in many cases, but trying to understand that would be helpful. Along those lines, as I compare the results in slide 38 to 30, no, I'm sorry. 38 and 39, the difference in Medicare, THCE and TME is quite small. I mean, it suggests that there's very little, if I'm understanding it correctly, very little administrative costs in Medicare, and with so many Medicare beneficiaries in Medicare managed care in California, it kind of raises my eyebrows on, are these data really right? And again, first time, but I think, comparing to external data sources and doing some helping the public understand, where you've got a lot of confidence and where there's less confidence in the data, I think would be very helpful.
Thanks, Rick. Yeah, so we didn't get into it in our board slides, but the baseline report does include a section on administrative costs and profits. And so MA, sort of per member per year, admin costs and profits did decrease by about 23% from 22 to 23. So in 22, it was about $964, and then it decreased to about $741. But I think to your point, we aren't in contradistinction to the enrollment and the spending data. We are relying on an external data source through CSIO and DMHC filings to get at that data, and so there could be measurement error among other sort of challenges.
Yeah, it wasn't so much the 22 to 23 difference, but just comparing, 18,501 for TME to in the next slide, 18,851. That difference of $351, which is about 2% of spending, seems too small, right? It seems like there must be more administrative costs than $351 given how many folks are in MA and what we know about the administrative costs and profits of MA.
Yeah, Rick, I actually asked Vishal the same question as we were going through, because it does jump out in the difference between the THC and TME. So page 28 of the baseline report does, as Andrew noted, have data specifically on administrative costs and profits, and we do see it go down from 22 to 23. So I hear you that we should check the veracity of the data. And by contrast, for both commercial and Medi-Cal managed care, there's 25% or more increase in administrative costs and profits.
Thanks. You went right where I was going to go, but before I do, this seems as good a time as any to just appreciate the extraordinary team that has come of public employees who've gathered here in OCA over the last 2.5 years. This report really does speak to the incredible work you all do. That commercial administrative cost and profit increase, that to me was the lead buried on page 26 of the report itself, 25% increase in commercial administrative cost and profit. I don't think I have heard any rationale for what's driving that, assuming the number is correct. I suspect it must be correct if the TME numbers are correct, because I have spoken to very few large group health plans who've got the kind of increases that you would infer from the slide that shows around about 5% TME growth by plan. I would love some more insight into whether it's having those plans come and explain what's driving that, or insight from the data as to what is driving a 25% increase in administrative costs and profit, and how that compares to other states. And it goes right to the heart of our charge, which is moderating the growth curve here. But also the increases here, you know, the percentages don't sound like much, but a $400-some increase in 1 year in a health plan cost for somebody who's making $25 an hour and trying to cover, you know, a family of 3, that equates to somewhere close to a 3% wage increase that they've forgotten, because that money had to go into paying for the increased cost of care, and that would that goes right to the heart of the affordability crisis in this state. So, you know, maybe in future, in the phase, you know, the 1B report next year, we could have a little bit more insight. And I don't know if you can, but I'd love to tease out, just as you have the TME by plan, the THCE by plan, so we can tell, you know, where that money's going.
Thank you.
Yeah, question follow-up for Rick. You mentioned, is a suggestion to include Medicare as kind of one category and not separate out duals?
Yes, I think it would be useful to, I mean, it'd be useful also to separate them out, but first include them and then show them separately. I think it would also be very useful to compare both spending levels and growth rates between Medicare Advantage and traditional Medicare.
And so, Rick, because I do struggle with where to put the dual eligible data, and so is that just based on Medicare being primary and more of the cost being spent by Medicare, except that because Medi-Cal covers long-term care services and those are so expensive, I wouldn't want those not to be accounted for.
Yes, I mean, I think it would make sense to include the Medicare spending for dual eligibles with Medicare, and then to the extent that we've got the Medi-Cal part, to be including that with Medi-Cal, and then needing not to double count as you're, you know, doing the denominators.
Yeah. And I don't know, Andrew, if we get the data that way, such that we could.
Sorry about that. Yeah, I think certainly DSNPs we could fold in quite readily. I think trying to decompose some of the dual eligible spending between Medi-Cal and Medicare can get a little bit thorny, but it's not undoable. So I think it just requires some careful work on our end.
Piling on appreciation to the team for getting to this point, and really appreciate the board's feedback on kind of the pulse check on where things are and where we might dig deeper. So very much appreciate that. I will open it up to public comment on the baseline report.
We will now take public comment on this item. Please step to the podium. And if you're attending virtually, please raise your hand. Please limit your comments to 2 minutes or less. Seeing no hands raised virtually at this time, we'll go to the podium.
Beth Capel for Health Access California. We're also pleased to see this report. We were a little surprised that the law didn't require public comment before it was released, but we will provide public comment nonetheless because we view this as the template for moving forward, and we appreciate the board discussion. We also very much appreciate the inclusion of a section on consumer affordability, and I want to emphasize something that wasn't as clear to me until I heard the verbal presentation today, which is the 3.1% increase in median income over the last 20 years is in the context of family share of premium and deductibles almost being twice that much. It's really remarkable when you think about how healthcare costs have increased from a family perspective for consumers in California, and I think that explains part of why we're here. And so we look forward to more discussion on the impacts on consumer affordability, and appreciate the work that the Labor Center has done to help model some of this, and appreciate the thoughtful work that's included in the report. Thank you.
Thank you. Looking virtually. Seeing no hands raised, back to the podium.
Good morning. Ben Johnson again from the California Hospital Association, just to give a few remarks on the release of the report. First, just noting the 8.4% annual growth in per capita healthcare spending is notable and is reflecting the reemergence really out of the worst pandemic in a century, making it anything but a normal 2-year period. Hospital spending, if you pool across the inpatient and the outpatient line, ultimately grew at a far lower rate than the statewide spending and was concentrated in outpatient, where we're trying to increase ambulatory care, which is less expensive and better for patients. Second, just want to align our comments with several from the board, really around concerns of an omission of really one of the highest contributors to per capita cost increases that is in the report, but was not highlighted in the summary. I think it was someone said bearing the lead. With the 25% or more growth in administrative costs and profits among health insurers, as compared to maybe about 5% growth on the medical spend side. So hugely striking figures. If you say average across the various markets, it's nearly 20% growth in spending that isn't related to any direct patient care, and is among the largest drivers. So for commercial spending, that component accounted for nearly 30% of the entire increase in year-over-year spending. So we encourage OCA to investigate and scrutinize this area of spending and oversee it as the major driver of healthcare cost growth that it is. Thank you.
Thank you. Looking virtually, seeing no hands raised, going back to the podium.
Good morning, Amy Blumberg on behalf of the California Medical Association, representing more than 50,000 physician and medical student members. First off, want to thank the staff. We appreciate all the hard work that went into the 2022-2023 baseline report. CMA is encouraged that OCA is looking at pharmaceutical costs as a major cost driver of overall healthcare spending. As the baseline report shows, prescription drugs accounted for at least 30% of the increased healthcare costs for commercial, Medi-Cal, and Medicare markets. CMA supports OCA considering the increased cost of drugs as a potential reasonable factor for exceeding the statewide spending target, which will impact medical practices that administer or dispense prescription drugs. Thanks.
Thank you. Continuing public comment, looking virtually, noting for the record we have about 75 virtual attendees. Seeing no hands raised at this time and no one at the podium, that concludes public comment on this item.
Thank you very much. And again, thank you to the team for that report. And we'll stay tuned for more. We are going to move to item 4B, the update on measuring hospital spending. And again, Deputy Director Pagani.
Thank you, Chair Johnson. So I want to spend some time to recap the work to date on hospital measurement. So at the, as many of you know, at the January 2024 board meeting, we had an introductory discussion on hospital measurement. And then taking us to, and that led to OCA convening monthly meetings of a hospital spending and measurement work group between April 2024 and September 2024. This work group provided input on measuring hospital spending. It included representatives from hospitals and health systems, health plans, state and private purchasers, and consumer advocacy. Representatives from hospital associations and organized labor participated as observers. Later in 2024, in November, OCA presented a provisional approach for hospital measurement. Board and public feedback primarily focused on improving the outpatient measurement approach to include a more refined data source for intensity adjustment. At the January 2025 board meeting, OCA confirmed the approach for measuring inpatient hospital spending. At our most recent April 2025 board meeting, we provided key updates on the outpatient intensity adjustment factor, including data sources and methodology. At the same meeting, we also recapped the approach for inpatient spending. So I'll take us to our next slide about how we'll measure hospital performance against the target using the measures listed here. So, for inpatient, we'll take inpatient net patient revenue from the HCI financials, and then we'll calculate it on a per case mix adjusted discharge basis so that we're getting to that unit price. And then, we have a footnote listed here that CMADs are essentially hospital inpatient discharges adjusted by case mix index, which is an available adjustment factor. And then the outpatient measure, it's essentially outpatient net patient revenue per adjusted outpatient visit. We take the outpatient net patient revenue from the HCI financials and then divide it by adjusted outpatient visits to get that outpatient price per adjusted visit. And then, as footnoted, the adjusted outpatient visits are hospital outpatient visits adjusted by the outpatient intensity adjustment factor under development. And on the next slide, I'll provide some next steps. So OCA is working to finalize the data sources, including validation related to the outpatient intensity adjustment factor. This summer, OCA will reconvene the hospital spending measurement work group to provide input on the outpatient intensity adjustment factor, as well as any considerations for OCA on how to measure and report hospital spending. We'll continue to provide updates to the board and the public. So this was a relatively short update, and as we get more progress, we'll continue to come back to the board. But just wanted to provide a kind of a full history of the work to date on hospital measurement.
Thank you. Questions from the board? Yeah.
Yeah, just alluding back to the last conversation, and this could equally apply to other sectors besides hospitals, but is one outgrowth of this continuing work of the work group going to be to better tease out what the administrative costs and profits are of the sector so that we can layer it on top of the payer admin costs and profits in future reports?
Yep. So the hospital measurement specifically is going to focus on net patient revenue for care delivered. So it's about payments from plans or payers to the provider, in this case the hospital. So that revenue does include administrative costs and profits. It could be teased out in a different way, not directly through the measurement. So the hospitals are required to the broader HCI annual financial data set does have revenue and expenses, so you could get to the operating margins. If you want to also look at non-operating revenue that's separate from patient care, kind of, which could be investment income, you could also get kind of the total margin that way as well. So at least with hospitals and health plans that file financial statements, that could be there's insight. We could get insight into that. For physician organizations, there's more limited data on that. The RBO financial statements are filed with DMHC, but they're not public. And then OCA has some future responsibilities for collecting additional financial statements from non-RBOs.
Thank you, Vishal. And I'm supportive of the approach that you're taking. For completeness, I think on slide 49, you might add how you would combine these two measures, unless the intent is to have separate targets for both inpatient and outpatient. But if the intent is to have a combined measure for the hospital, then you probably should specify how to do.
Yeah, we're actually having active conversations on that right now. So the goal is to have a combined measure, but at the same time, we want to disaggregate it by inpatient and outpatient so we could see what's changing and it'll allow us to kind of monitor shifts to outpatient. And then also by payer type, so we could get kind of a commercial breakout in Medicare and Medi-Cal. That is something we'll take to the work group to get their feedback on.
Great. Not seeing any other questions from board members, we will open it up for public comment.
We'll now take public comment on this item. Please step to the podium. If you're attending virtually, please raise your hand. Please limit your comments to 2 minutes and to this agenda item. We'll go to the podium.
Good morning, Jenny Nguyen with the California Hospital Association. We look forward to the reconvening of the hospital spending measurement work group to determine the methodology for measuring outpatient spending. However, we ask that OCA bring forth to the work group for discussion and feedback the data sources to be used for the outpatient intensity adjustment factor before it is finalized and a methodology is determined. This is critical because the proposed use of the healthcare payments database, or HPD, to determine hospitals' outpatient intensity adjustment score is a new and untested data source. Specifically, while hospitals have some experience with the ambulatory payment classification system, we have yet to identify a hospital with experience using the enhanced ambulatory patient groups methodology. We also have concerns about the reliability and the accuracy of the OIA when combining hospital and payer reported data. There's lots to tease out here. For example, hospital reported data include all hospital visits, while a big proportion of these visits will be missing from the HPD, since reporting for the self-insured is voluntary. Lastly, we ask that any data and methodology determined should be transparent to allow for validation and assessment by regulated entities. We look forward to discussion of these issues at the workgroup meeting. Thank you.
Thank you. Looking virtually, seeing no hands raised, noting for the record, we have about 70 virtual attendees. Going back to the podium.
Hi, good morning. Angus Cochrane with Washington Health in Fremont. Just as a reminder, we're an independent district hospital, a non-designated public hospital, and we're the only hospital in Southern Alameda County that accepts Medi-Cal patients. So late last month, we met with the OCA staff. I want to thank Deputy Director Pagani and staff for meeting with us on a Friday before a long weekend. The purpose of the meeting was to go through our annual financial filings with HCI, which we believe have miscategorized certain healthcare data related to our self-insured status. The cost for ensuring the Washington Health workforce are directly borne by the institution, and obviously these services provided to employees and their families are not revenue generating for us. These services are in fact an expense with no net patient revenue. So I just want to let board members know that we will resubmit our data to HCI this week for 2021 through 2024, and we understand it will take some time for the staff to work through our HCI resubmission, but we hope that the staff are in a position to complete their recalculations and provide an update to the board meeting on July the 22nd. We believe that our refiling will demonstrate that Washington is below the 85th percentile for the two metrics OCA is using to evaluate hospitals, and that being the case, our request is that the Washington Health be removed from the high-cost hospital list at the earliest opportunity. We'd also like to ask that the OCA board make a public statement at the July board meeting that OCA staff is working with Washington to reconcile reporting and to reevaluate its inclusion on the list. Thanks for your time and consideration.
Thank you. Seeing no hands raised, back to the podium.
Beth Capel for Health Access California. We spoke to this in our letter and we weren't going to speak to it here, but we appreciate that as this data is used, including from the HCI hospital financials and discharge data, that it will draw closer scrutiny and thus involve some of the recategorization of data, whether it's North Bay or what we just heard from Washington. Though we understand that that's going to occur. We ask that the staff report that there be routine reporting whenever that occurs. We should be, and the board should be able to track when there's data revisions that have consequential impact. And we made a series of suggestions in our letter about that because we were troubled that there's now an incentive to go back and revise data. I would also add that it would be good if the HCI financial data is subjected to some sort of external validation. Mischaracterizing Medicare Advantage as commercial is a big error that should have shown up. It won't show up if you do a desk audit for completeness. It would show up if you compare it with any other data source. So we just suggest some more careful validation of the data that's been filed and attested to by the individual hospitals. Thank you.
Thank you. Looking virtually, seeing no hands raised. Going back to the podium.
Thank you. Francisco Rodriguez with the Monterey Bay Central Labor Council. And I do apologize, not sure if this is public comment for a specific item or just public comment in general. However,
this is related to this agenda item. The general public comment period is at the end.
But it's about hospital spending measurement.
Sorry, thank you.
Thank you. I appreciate it. Well, just as I was saying, Francisco Rodriguez with the Monterey Bay Central Labor Council. We have around 80 affiliates in both Monterey County and Santa Cruz County. And we're here to say, first of all, thank you for the work that the board has been doing and the work that the staff has provided. As you know, healthcare in California is very expensive, and the limits that you have set, I think, are fair, and we hope that you have or you're able to enforce them, and specifically for the limits on hospitals. As you know, you identified 7 of the most expensive hospitals in the state. 3 of those happen to be in the Monterey Bay region. Chomp, Salinas Valley, and Dominican Hospital. Our members are hit really hard by these healthcare costs, as well as our employers and our community in general. We're here with communities organized for relational power in action, the IAF affiliate in the Central Coast, and we're here to advocate for healthcare. We knew that this was happening, and so we just wanted to stop by. First of all, thank you for your work, and second, let you know that we're here to support and make sure that you have the resources to enforce those limits and to make healthcare affordable in California for all Californians. Thank you very much.
Thank you. Continuing public comment. Looking virtually, seeing no hands raised, and no one at the podium. That concludes public comment on this item.
Thank you for the continued work and more to come in that space. We are going to take a 30-minute lunch break now, and we will resume at 12:20, and we'll return with the item 4C, the update on the behavioral health definition and investment benchmark. Okay, we're going to take a 40-minute lunch break, and we will reconvene at 12:30. Thank you. Welcome back from lunch. I will call us back to order. And if we can do a roll call, please.
Dr. Sandra Hernandez.
Present.
Secretary Kim Johnson.
Present.
Richard Cronick.
Present.
Ian Lewis.
Present.
Elizabeth Mitchell. Dr. Richard Pan. Don Moltz.
Here.
5 present.
Wonderful, thank you. We will reconvene with item 4C, the update on behavioral health definition and investment benchmark. I'll welcome Margarita Brand, Assistant Deputy Director of the Health System Performance Branch, and Debbie Lenz, Healthcare Delivery System Group Manager. Thank you.
Thank you. Good afternoon, members of the board. So this afternoon, Debbie and I will provide an update on the behavioral health workstream, including analyses of behavioral health spending data that we've reviewed and shared with our investment and payment work group, an overview of the behavioral health investment benchmark proposal that we recently shared with the work group and their feedback, and then also share a new recommendation to focus on data collection and measurement before setting a benchmark. And we look forward to your feedback on this new recommendation. So if we can move to the next slide. As a reminder, just starting with our statutory requirements, so we have two related but distinct activities for behavioral health spending. First is to measure the percentage of total healthcare expenditures that go towards behavioral health. And second, OCA is required to set a benchmark for behavioral health spending that sustains infrastructure and capacity and shifts resources towards supporting and facilitating innovation and care improvement in behavioral health. And the statute does not require that the benchmark be set by a certain date. Since it has been a while since the board discussed the behavioral health workstream, we wanted to start by reviewing some feedback we received from you all, summarizing the feedback from the February board meeting, and then also other feedback we've received recently, and then also share some background about the rationale for our proposed benchmark focus. So we can move to the next slide. So this slide is a summary of the feedback we heard from you all in February. And here we'll start with that given OCA plans to begin collecting behavioral health spending data from commercial and Medicare Advantage payers, board members stress the importance of adding Medi-Cal in the future and of keeping this in mind as we develop our specifications for the definition and data collection. There was some discussion of the proposed focused behavioral health investment benchmark and interest in the rationale for excluding inpatient spending from that proposal. Board members also expressed interest in tracking the spending for inpatient behavioral health care, pharmacy costs, and payment rates for behavioral health services over time. There was interest in capturing spending for behavioral health care delivered in a school setting. And also discussion of ways to track behavioral health transformation occurring across the state. And last, there was interest from board members in understanding the reasons for access gaps and low network participation from payers and providers. And we'll spend a few minutes looking at those reasons in a moment. Next, we can move to the feedback from the advisory committee meeting in March. So this slide summarizes the feedback we received when we presented a progress report to the advisory committee. So regarding the benchmark, advisory committee members expressed support for structuring the investment benchmark as a per member per month amount rather than as a % of total medical expenditures. There was mixed support among members for the recommendation that the benchmark focus on outpatient and community-based spending. Members appreciate the desire to incentivize increased access to upstream behavioral health care, but also pointed out that there are access challenges across the care spectrum. Some comments focused on recognizing behavioral health in part of a larger picture of an individual's health, and members expressed the importance of integrating or incentivizing integrated behavioral health care and primary care, and some were concerned about missing spending for primary care if only the primary diagnosis is considered in the definition. There was also interest in understanding if encounter data diagnosis fields were well populated to identify behavioral health spend. Other comments expressed concern that measurement of clinical spending by payers misses important parts of the behavioral health support system that is outside traditional healthcare settings. And then last, there was concern about incentivizing untested approaches to behavioral health care, such as the use of artificial intelligence through the benchmark, the proposed benchmark. So next, summarizing two more meetings that we've had since the board last met, our investment and payment work group at its March and April meetings shared valuable insight and feedback on issues of measuring behavioral health spending and how to frame the investment benchmark. So work group members again stressed the importance of preventive behavioral health services and that the approach to measuring behavioral health behavioral health spending should reflect this importance. In discussing the services that should be included in the definition of non-claims behavioral health spending, the work group expressed support for including payments to peer support specialists in the measurement of payments for social care integration. Work group members raised the question of whether mobile crisis services are part of the outpatient and community-based services proposed for the focus benchmark, and we confirmed that they are. In the benchmark conversations with the work group, they addressed key decisions that need to be made about the work group, how to measure it and present it, whether the emphasis should be on short-term versus incremental improvement or long-term benchmark, and what the time horizon should be for achieving the benchmark. The majority of work group members have supported framing the benchmark as a per member per month amount. And there is also strong consensus that spending should be measured and reported both as a per member per month amount and a % of total spending. Most work group members support a benchmark with both an incremental improvement component and a long-term goal. And consistent with this, regarding the time horizon, there is strong support for a time horizon that aligns with the alternative payment model, adoption goals, and the primary care investment benchmark. However, given the current uncertainty about baseline and the relative lack of data for behavioral health spending, there's also an interest in revisiting the benchmark at shorter intervals and having flexibility as more data become available. So we will share more feedback from the work group meeting in May later in our presentation, and in our next slides we'll share some information about the rationale for our proposed benchmark focus. So yes, this next slide summarizes evidence related to out-of-pocket costs for behavioral health care. So OCA's proposed benchmark focus on in-network outpatient and community-based services is based in part on incentivizing payers to improve access to these services. And these next few slides present evidence regarding high out-of-pocket cost burdens, low in-network access to care, and barriers to behavioral health provider participation in networks, which address some of the questions raised by the board members in February. So to begin, surveys and other studies have identified out-of-pocket costs as a barrier to access. More than 1/3 of adults in California with mental health treatment needs reported not receiving care due to costs, according to a recent California Healthcare Foundation survey. And not surprisingly, low-income people are more affected by out-of-pocket costs, with one analysis of the medical expenditure panel survey data finding that 1/8 of patients with mental health conditions whose family is low income or whose family income is below the federal poverty level spend 10% or more of their disposable income on mental health services. And out-of-pocket spending is a larger issue for those with mental illness than those without. A Kaiser Family Foundation analysis of a large commercial claims database found that for privately insured individuals treated for depression or anxiety, out-of-pocket costs were almost double those of adults without a mental health diagnosis. And then turning to our next slide. So the California Healthcare Foundation and the Department of Managed Care recently documented the challenges health plan members face when seeking an in-network behavioral health provider. A CHCF survey found that in 2023, more than half of respondents who tried to make a mental health appointment had difficulty finding a provider that takes their insurance. Access to in-network psychiatrists and psychologists is quite restrictive relative to medical surgical specialist physicians. Californians went out of network for psychiatrists and psychologists 15 times more frequently in 2021, according to an RTI International analysis. And last, the Department of Managed Healthcare, DMHC's investigations of 4 health plans found that members of 3 of these plans had difficulty accessing behavioral health services. And then we have a few more slides getting into the barriers to behavioral health provider participation in health plan networks. So from the provider perspective, First, in-network reimbursement rates are lower than rates paid outside of networks, and many mental health providers find it economically viable to opt out of networks and charge higher prices. And then also behavioral health providers who are solo practitioners or have small practices may not have the infrastructure needed to handle the administrative demands of contracting with health plans. Some providers report limitations imposed by insurers on providing care that restrict their ability to practice. And these restrictions could include benefit design, prior authorization, or utilization management, or claims denials. And then finally, we frequently have heard of the issue of ghost networks coming up in members seeking access to care. So many insurers' provider directories may not be up to date or accurate, or the listed providers may not be accepting insurance or accepting new patients. This was shown by a 2022 study published in Health Affairs and a 2022 report from the United States Government Accountability Office. And then next, wanted to turn to the impact of behavioral health care on health outcomes and total spending, just as more rationale for the focus of our benchmark approach. So there is strong evidence of the positive effects of improving access to outpatient behavioral health care on health outcomes and on total health care spending. In particular, the collaborative care model of integrating behavioral health and primary care has shown to be very effective in improving the health of people with anxiety and depression. Here we summarize a few research studies. First, a systematic review by the Cochrane Collaborative found that collaborative care for patients with depression or anxiety resulted in significantly better outcomes than other types of care delivered to randomized control groups. Another randomized study found a significant and lasting improvement in the number of depression-free days for patients who received collaborative care compared to usual primary care. And another randomized study found that collaborative care also improved medical outcomes for patients with chronic illness such as depression or diabetes and cardiovascular disease, in addition to better outcomes for depression. And last, in our evidence summary, this slide details some evidence for improving access to outpatient behavioral health services as a cost containment or cost reduction tool. One study found that outpatient behavioral health care for newly diagnosed patients resulted in reductions of total health care costs from an average of $464 per member per month to $391 over 27 months. On a broader scale, the actuarial firm Milliman estimated that integrating behavioral health with primary care could reduce national healthcare costs by between 38 to 68 billion in 2018 dollars. And a 2024 study found that a reduction in per member per month claims for mental health care and overall for patients in a 2-year collaborative care model pilot program. So we wanted to share that evidence and that summary of the feedback that we've heard to date before we turn to our behavioral health spending analysis. And I'll now turn it over to Debbie to walk through that.
Thanks, Margaretta. Good afternoon. I'm Debbie Lindis, manager of the Healthcare Delivery System Group at OCA. And you can go to the next slide. So OCA collaborated with HCI's Healthcare Payments Database team on an analysis of several years of spending data in the HPD. We also looked at analyses that covered California and CalPERS have done on their own data. And the data we'll look at from these analyses provides helpful context for the discussion of the benchmark proposal that will follow later in this presentation. So the HPD team analyzed HPD claims over the 6-year period 2018 through 2023 using a methodology developed by Milbank Memorial Fund to identify behavioral health spending to provide us with a baseline understanding of mental health and substance use disorder spending via claims prior to OCA starting to measure the spending and set benchmarks. Covered California and CalPERS also used this methodology for their analyses. And as a refresher, the Milbank Memorial Fund convened experts from several states, including California, and our colleagues from Friedman Healthcare to develop this consensus recommendation for measuring claims and non-claims behavioral health spending. Go to the next slide. So this is a process map that illustrates the basics of the Milbank methodology for identifying behavioral health claims. Starting at the top left with the blue box, the first step is to determine whether the claim includes a behavioral health diagnosis in the primary diagnosis field. If the primary diagnosis field does not contain a behavioral health diagnosis code, the claim may still be considered behavioral health if it includes a service code for mental health or substance use disorder screening or assessment. The orange box recognizes that screening for mental health and substance use disorder conditions is important for prevention and population health, regardless of the resulting diagnosis. And OCA believes its measurement approach should incentivize these important services. So if one or more of those services is on the claim, then those lines of the claim are considered behavioral health. Going back to that first blue box, if the claim includes a behavioral health diagnosis code in the primary diagnosis field, then the next step is to categorize the service by place of service, revenue, and service codes. So any claim that clears the primary diagnosis hurdle will be considered a behavioral health claim. And this second step categorizes claims for analysis and later will allow us to determine what will be included in comparing spending to the focused benchmark. The separate flow, starting with the blue box on the right side of the slide, shows the process for identifying pharmacy claims to be included in measurement. If a pharmacy claim includes a National Drug Code, or NDC, that OCA defines as behavioral health treatment, then the claim is considered a behavioral health claim. And I'll also note that all behavioral health claims will be categorized as either mental health or substance use disorder spending, depending on the primary diagnosis code, or NDC, on the claim. Can go on to the next slide. And here I'll just make a few more comments on the analysis before we review the findings. So first, the findings presented here today are preliminary and are limited to the commercial market. Medicaid, Medicare Advantage, and Medicare fee-for-service spending are not included. And this commercial analysis includes data from the mandatory data submitters to the HPD, which is fully insured plans and CalPERS, as well as voluntary self-insured submitters. The spending analysis includes claims data that has associated spending in the HPD. So this spending largely reflects fee-for-service payment arrangements, but includes the claims-based spending for some other payment types, such as bundled payments. To comply with de-identification guidelines, claims records with fewer than 30 claims were suppressed, and therefore the associated spend was excluded from our analysis. And we're grateful to Covered California and CalPERS for also analyzing behavioral health spending from 2021 through 2023 using their claims and encounter databases following the Milbank specifications. Although both agencies applied the Milbank code set, their methodologies may have differed in some ways. For example, the way they used capitation and encounter data to estimate claims equivalence. So we should consider all of this analysis preliminary, including the HPD analysis, and consider the comparisons approximate. You can go to the next slide. And so here we have the overall trend in behavioral health spending by commercial payers from 2021 through 2023. The Covered California and CalPERS data show consistently that behavioral health services accounted for between 5% and just over 6% of total medical expenses during those 3 years. The Covered California data show a gradual increase over time, while CalPERS shows an increase in 2022 and then a decrease in 2023. And both data sources show that mental health services, the blue segments on the bars, account for most of the behavioral health spending, with substance use disorder services taking a smaller share. In the HPD data, the level of spending for behavioral health is higher as a percentage of total claim spending than CalPERS and Covered California found. The HPD data also shows a gradual increase over the 3 years in behavioral health spending as a portion of total claim spend. Next slide. So this is some data from Massachusetts as a comparison with the California data we just looked at. This chart shows 2 years of data for commercial payers, Mass Health, which is Medicaid, and Medicare Advantage payers. The commercial segment measurement is comparable to the data we just looked at from the 3 California sources, showing the percentage of total expenses going to behavioral health is 7.7 or 7.8%, with a large majority of that spending being for mental health. Behavioral health spending by Mass Health is quite a bit higher than the other 2 categories, and there are likely several reasons for this. First, Mass Health has a higher percentage of members with a mental health diagnosis than payers in the other 2 categories, and a significantly higher percentage of members with a substance use disorder diagnosis. Also, it's likely that Mass Health has a greater proportion of members with dual mental health and substance use diagnoses, and single diagnosis members with more intensive needs. So the utilization is probably higher. Mass Health provides more extensive coverage than commercial and Medicare Advantage plans for mental health and substance use disorder services. And Massachusetts has also focused policy efforts through its behavioral health roadmap on increased access to behavioral health services for Mass Health members. So we don't yet have comparable data from Medi-Cal to share, but it's reasonable to anticipate that we'll see a higher level of behavioral health spending in Medi-Cal than in the commercial and Medicare Advantage markets in California. Next slide. So this chart shows the trend in behavioral health spending from 2018 through 2023 from the preliminary analysis of HPD claims data. The light blue portion of the bars here shows the categories of behavioral health spend that OCA is proposing to use for its spending benchmark in network, outpatient, and community-based behavioral health services. The gray portion of the bars represents all other behavioral health spending. So a couple of things to point out are first, that there's been a steady increase in total behavioral health spending as a percentage of total claims spending, growing from 6.6% in 2018 to 8.2% in 2023. And second, the increase has been driven by increases in that in-network outpatient portion of the spending, which increased from 2.3% of total claims spending in 2018 to 3.6% in 2023. The rest of the behavioral health spend was relatively flat over this period, meaning that it grew at approximately the same rate as total medical expenses. Next slide. So the steady increase in the portion of behavioral health spending that OCA is proposing to use its benchmark, which obviously occurred before the introduction of the benchmark, has implications for setting the benchmark. So to further inform our thinking, we looked at the annual changes in spending for in-network, outpatient, and community-based behavioral health care. This chart shows year-over-year changes in the targeted spending measured as a percentage of total claims spending. There are substantial year-over-year gains in the benchmark measure of in-network, outpatient, and community-based behavioral health spending as a percentage of claims spend, reflecting the trend we saw on the last slide. And these increases reflect the increases in spending in the outpatient and community-based behavioral health categories, but those changes are moderated by growth in total claims spend, which is the denominator of this measure. So the range here is from 1% increase in 2021 to 18% in 2023. And that 1% in 2021 was a year when total medical expenses grew significantly, rebounding from the COVID-19 pandemic. The simple average of the 5 years increases is about 10%. Next slide. So this chart shows year-over-year increases in the spending per member per month for the target categories of behavioral health spend. And this year-over-year increase ranged from a low of 9% in 2020 to a high of 24% the following year, with an average increase of approximately 16% across the entire time period. The year-over-year change in percent of total claim spend that we saw in the last slide is lower than the percent change for PMPM, except for that pandemic year of 2020, because of the moderating effect of the growth of total spend. So in contrast, the per member per month measurement is independent of trends in total medical expenses, and it reflects changes in spending that are not the result of changes in membership. We can go to the next slide. So we wanted to know more about what's behind these trends, and so we began by looking at the trends in spending for the service subcategories that make up behavioral health care. This table shows the percentage of total behavioral health claims by commercial payers attributed to each subcategory by year. And I'll note here that this is the first time HPD cost information is being displayed for behavioral health services. And I will reiterate that these findings are preliminary. The fastest growing components over the period were residential facility services, which grew from 4% of the total to 9%, and outpatient non-primary care professional services, which grew from 33% to 43%. In contrast, the share of spending for inpatient facility and emergency department services declined over the 6 years. Next slide. So this chart shows the distribution of commercial behavioral health spending across the service subcategories for 2023 graphically. The largest share of spending, 43%, is for outpatient professional non-primary care services. Including outpatient professional primary care, outpatient facility, and mobile services, the data show that outpatient services account for more than half of the behavioral health spend by commercial payers. Next slide. So, as we did for primary care, OCA is compiling a list of supplemental analyses that would provide further insight into efforts to increase behavioral health investment, but that would not be part of the measurements of spending using the data that payers submit to OCA. The behavioral health spending data we just looked at raises additional questions that could be answered with further analysis of existing and future data. And while these analyses would take time and resources, and they might not be necessary to inform the benchmark approach, they can enhance our understanding of the drivers of the spending we just reviewed. So some of the questions we've identified for supplemental analysis thus far are certain services driving the trend in in-network, outpatient, and community-based behavioral health spending? Are there particular diagnoses driving the trend? How did changes in price and utilization contribute to the trend? And we've seen the average growth across payers, but how do trends vary among individual payers? Go to the next slide. Oh, okay. Yeah, go ahead.
Yeah, so since a little bit adjustment, but since we have time on the agenda, we figured we might pause for questions here before moving to our benchmark proposal and our recommended approach. So any questions on either the summary of feedback we recently received or this data analysis?
Thank you for this. I'm curious, where does telehealth fall in the service categories that you're looking at as subcategories?
So telehealth services would be included in the respective subcategory that they apply to. So generally they would fall in the outpatient community-based services subcategory, or if we could go back one slide. They would generally fall in the outpatient professional non-primary care if that was how the service itself was categorized. So they're, and correct me if I'm wrong, Debbie, but they're essentially categorized how they relate to these subcategories. So if it's related, if it's in the outpatient professional primary care bucket, it lands there. If it's in the outpatient professional non-primary care, it would land there.
So it really just depends on. So telehealth can be delivered in a number of different ways. So I'm just trying to figure out, are you coding it based on who's actually providing the service or where the individual got their care?
Sure. Yeah, so it's who's providing the service. So if it's a primary care provider, it would be in the primary care bucket. And then otherwise, I'm pretty sure that almost all of it is going to be outpatient in the outpatient category. And so it's a subcategory of the outpatient set of places of service and revenue codes. Is the telehealth is a place of service.
Thanks. I found myself on slide 67 reflecting on first off, this is fabulous, albeit preliminary data out of the HPD, but that consistent kind of 2% above the CalPERS and Covered California estimates. I found myself trying to imagine what was driving that, especially since all of these numbers are kind of higher than what I've experienced in my own experience with plans. Two areas I'm curious about. One, do you know if there's a big differential between plans that provide a lot of capitated behavioral health versus plans that presumably the HPD numbers are still heavily claims or entirely claims based? And then secondly, while I wholeheartedly agree that we should incentivize and include screening here, I do wonder about the 30-minute visit where, you know, there's a 20-second one-off question that qualifies the screening, and I wonder just what proportion of this this total is screening as opposed to ongoing delivery of care. Do you have any insights into those?
No, we would need to look at that specific set of procedure codes or is it procedure codes or diagnosis codes to determine what portion of that counts towards this spending.
Yeah, for the screening, so there's lines on the claim that have a CPT code for the screening service, and I believe that those actually have been associated with them that's separate from the total spend of the visit, and often it's zero, actually. So there may be, I think we may be actually underestimating the amount of effort that's going to that because a lot of those don't have any spend, but the whole visit does not go. So if there's like a 9921 E&M code, that part of the spend is not included.
And then are you able with the HPD data to do this analysis, stratify it on a, in terms of, focus on diversity, on equity rather, by demographics and or geography?
We have good geography data in the HPD. Our race ethnicity data is not nearly what I would want it to be in the HPD. So, for example, we have not done public reporting of race ethnicity data in the HPD, although I think we should because I think the plans aren't giving us that should be made public. So yes, we can do some, and there are some lacking data. Language is a little bit better.
Thank you for this analysis. Why was the HPD analysis restricted to commercial and not including Medicare Advantage and Medi-Cal?
So we just started there with this preliminary analysis. This is our first time running this analysis. I think, one also reason that we focus there is because it's a bit more comparable to the Covered California and CalPERS data. But I think we have the opportunity in the future, especially to look at Medicare Advantage.
And for encounters in the HPD data where there is no payment, so encounters that were presumably covered by capitation, you're not including the zero payment in the numerator. Are the payments, if there were payments for those people for non-behavioral health services in the HPD, are those payments in the denominator?
This analysis is just based on claims data, so it doesn't include any encounter data.
And it's claims data for both the numerator and the denominator?
Yes.
Yeah. Okay, thank you.
Any other questions? Yeah.
Marguerite, you are going to look at Medi-Cal data.
Say that again?
You are going to look at Medi-Cal data eventually, yeah?
Yes, the idea is to get Medi-Cal data eventually, and also we, as a preview of our recommendation, we are recommending that we move forward with collecting behavioral health spend data from Medi-Cal managed care plans, and continuing to work with DHCS to understand the broader behavioral health spending across the Medi-Cal delivery system.
And so that will include county mental health specialty as well?
The coordination with DHCS to measure spending outside of Medi-Cal managed care plans would include county spend, yes.
And again, really a good start. So these questions are just meant to tease the future. And then I think there was a recommendation from the advisory committee, but how are we thinking about understanding the behavioral health costs in our carceral services?
We have not looked at that yet, but we are happy to dig into that and think about how that would coordinate. I think we're focused really on behavioral health spending by payers, and since that is our data collection process and the scope for the investment benchmark.
Sandra, the question was about correctional health care. So we do have the spending data for them, for that category of spending. It was included in the THC numbers in the baseline report. We could take that back and see if there is any more granularity in terms of service category and look into that. But it wouldn't be part of the benchmark, but it would just be additional data on spend.
Sort of broken record, but if we're sort of reviewing past discussions, the out-of-pocket, out-of-plan spend, as we've talked about, and as I know you know, is a big concern. And I don't think we've come up with any magic bullets about how to get that. Although maybe a survey of therapists to try to get some estimate of what their revenue structure looks like and how much revenue is coming from out of pocket might be a way to get there, if anybody is willing to fund such a survey.
Such a really good idea.
Okay, if no other questions about the analysis right now, and we can come back to it if helpful, wanted to walk through our benchmark proposal based on that, incorporated in this analysis and the feedback we heard from our work group and a new recommendation, and solicit your feedback on this recommendation. So if we could move to the next slide. So this is a reminder of our proposed benchmark structure. This that we recommend focusing the benchmark on in-network outpatient and community-based services. For claims-based spending, this means the 4 subcategories that are listed on the side as defined by diagnosis, service, place of service, and revenue codes. And then for non-claims-based payments, that would be part of the benchmark, include payments to providers for population health and practice infrastructure payments, pay for performance or pay for reporting payments, and to these types of behavioral health providers, and then also a portion of capitation payments that are for services in the outpatient and community-based subcategories. And the goal is to identify those through encounter data. So, and then moving, just a brief reminder of our other benchmarks. And so we just used our other benchmarks to inform our potential approach to the behavioral health investment benchmark. So the healthcare spending target is focused on a spending target from 2025 through 2029. The alternative payment model adoption benchmark and the primary care investment benchmark both combine short-term incremental improvements and long-term goals. And emphasizing that those short-term improvement goals acknowledge that payers are starting in different places, but improvement is expected for all, and also allows for adjustments as new data improves, as new data becomes available. And moving on to our next slide. So we brought a draft proposal for the behavioral health investment benchmark to the investment payment work group in May. We proposed that the benchmark would be implemented in 2 phases, largely because of uncertainty about where payers are starting in terms of their outpatient and community-based behavioral health spending, and the related uncertainty of what improvement is reasonable to expect for payers to achieve, at least in the short term. So the first phase would cover performance years 2025 through 2029 and would require each payer to increase its spending on in-network, outpatient, and community-based behavioral health care as set by a set percentage each year. And the percentage would be informed by the trends in behavioral health spending that we are seeing from the HPD data and Cover California and CalPERS data. 2025 would be the baseline year with increases expected over the following 4 years. The baseline spending amount would be derived from each individual payer's spending in 2025, and we are assuming here that baseline amounts will vary across payers and lines of business, but that increases in spending would be warranted for all. OCA would assess each payer's performance against its benchmark every year, and in 2029, OCA would use 2027 data to assess each payer's performance to date and make decisions about the next phase of the benchmark. And phase 2 for 2030 through 2034 is on the next slide. So again, this was our recommended proposal. So in 2029, OCA would update the benchmark for performance years 2030 through 2034, informed by experience of the first few years. OCA would reset the annual incremental benchmarks and would consider setting a long-term investment benchmark across all payers to be achieved by 2034. This timeframe would align with the longer range primary care investment benchmark and alternative payment model adoption benchmarks, which are both set for a year end of 2034. And then here we also flagged that at this point, if not sooner, OCA would also incorporate benchmarks for Medi-Cal payers in collaboration with DHCS. So this next slide walks through our rationale for this proposed approach, and then we'll get to the feedback we heard from the work group on this proposal. So this proposed 2-phased approach with an opportunity to recalibrate at the midpoint of a 10-year period was driven by several considerations. First, it seems clear from access and quality information and from the insights of stakeholders that it is desirable to increase spending on outpatient and community-based behavioral health care, both as a share of total behavioral health spending and as a percent of total medical expense. And as we saw earlier, the HPD data shows that this portion of behavioral health spending has been growing in the commercial market at an average of 16% per year, measured as per member per month amount, even before the encouragement of a benchmark. However, there are information gaps about behavioral health spending which were not necessarily as much of an issue in our work on primary care that make it difficult to set incremental or long-term benchmarks for behavioral health spending that would extend through 2034. For example, we don't have much insight yet, which is why we flagged the previous suggestions for additional HPD analysis. We don't have much insight yet into what is driving these recent spending increases or how spending levels or trends vary across payers. We do not know where each payer is starting from currently, and we also do not have strong evidence for what the so-called right level of spending is for this portion of care. For primary care, there was a fair amount of state and international experience and a lot of research and literature to guide us about increasing primary care spending. And these considerations brought us to the idea of using each payer's own spending as in 2025 as the baseline, and then planning to take, to reassess in 2029 when we would feel like we would have more information from a few years of data collection. And by then, we would hope to have enough data and knowledge in 2029 to confidently set new benchmarks through 2034. So if we can move to the next slide, we presented the data analysis that we presented you all earlier today and this proposal to our work group in May. So on the data, members appreciated seeing data on actual behavioral health spending from the HPD, Cover California, and CalPERS to provide some context for our conversations about measurement and benchmarks. And while some were surprised in a positive sense by the level of behavioral health spending in 2023 and the increase since 2018 that the data showed, others said it was consistent with their expectations. And as with any data analysis, as we noted earlier, the presentation raised additional questions. Work group members would like to know what factors are driving the overall trends and what the variation in spending is across payers. These questions were on our list of supplemental analyses earlier. In addition, there was interest in seeing a breakdown of spending by subcategory. We conducted that analysis following the meeting, and the table and chart we showed you earlier shows this breakdown, but we did not have a chance to share that with the work group. So, and moving to the next slide. So this slide summarized the feedback we heard on our benchmark proposal from the work group. So overall, there was support for the iterative phased approach that OCA proposed to take advantage of the opportunity to learn from experience and from the analysis of additional data. There were also a number of reservations about the benchmark as proposed, which in many ways were consistent with our rationale for the two-phased approach. So based on preliminary data analysis that we present, several work group members were really interested in knowing about past trends and drivers of growth in behavioral health spending, including the variability in spending increases from year to year. There was a desire for clarity that the benchmark would support equity and access goals. One concern is that the benchmark would not capture programs that promote equity and access outside of claims-based care. The uncertainty about payer-specific starting points and the lack of information about what the right level of care to be targeting made some members apprehensive about setting specific targets in for annual growth and spending. And then, as we've discussed several times, members raised questions about how payments for specialty mental health services under Medi-Cal would be incorporated into the benchmark. And there was a suggestion to potentially further refine the benchmark to focus on integrated behavioral health in primary care. So moving to the next slide. So we considered the work group's input and incorporated it into an updated recommendation for the benchmark. So this is our proposed recommendation, and this is a new approach, and wanted to solicit all of your feedback. And of course, we'll go back to the work group and the advisory committee. So OCA proposes that the benchmark be set in spring of 2028 and apply to spending for performance year 2029 and onward. The benchmark would be set based on data that OCA would collect from payers for performance years 2024 through 2026, and on further analysis of HPD data and an assessment of the impact of behavioral health policy efforts that are now being implemented in California. So this approach would allow more time for OCA to learn from the data that payers submit for measurement of behavioral health spend before setting the benchmark. It also allows OCA to identify and resolve challenges with the data submission process. So the definitions of behavioral health spending and the data submission measurement protocols are all new, and OCA could benefit from time to better understand how payers respond to them and submit their data and make necessary adjustments. It also provides OCA time to conduct further analyses using HPD data to better understand the drivers of spending trends we see in this preliminary analysis. And of course, the trade-off of this approach is that any impact the benchmark might have on policy goals would be delayed by 2 years. So moving to the next slide. So if the board is supportive of this recommendation, we would propose these next steps to focus on behavioral health spending measurement in the coming months. First, OCA would finalize the proposed definitions of claims and non-claims behavioral health spending, and for the behavioral health in primary care module that we're using to measure behavioral health spending in primary care settings, with input from the advisory committee and the work group at their June meetings. Next, we would bring those definitions to the July board meeting to receive your input. And throughout the summer and fall, OCA will work with DHCS to ensure that the behavioral health definitions developed are aligned with Medi-Cal managed care plans, covered services, and payment mechanisms. And the development of Data Submission Guide version 3.0 will support the start of behavioral health spending data collection from commercial, Medicare Advantage, and Medi-Cal managed care plans beginning in the fall of 2026. And we would also continue to work with DHCS over this time period and stakeholders to measure behavioral health spending in the broader Medi-Cal delivery system. So in the next, on the next slide, just are, again, some discussion questions. So we'll pause here and invite your reactions and discussion about the spending data we present, if there are any additional questions there, and then your thoughts on the proposed approach, the proposed measurement first approach, and potentially deferring setting a benchmark until 2028. And of course, any other input you may have.
Thanks. In terms of the overall approach, I think it's clear there's enough gaps in the data we have to work with that it makes sense to me. I think two things I wanted to raise. One, I'm quite concerned to figure out, with regard to capitated or non-claims-based payments, how we calculate what portion of those payments really are going to behavioral health. I think I saw in some of the materials that we didn't get to in the last meeting a reference to using some kind of standard benchmark. I might have got that wrong, but when we do get round to figuring out how we attribute spending, I'd be very cautious not to overestimate what is being actually spent down the veil of capitation. The other was more of a question. Our state has probably some of the best laws in the country in terms of timely access, but they've proved very difficult for the state to enforce. And I'm wondering if there's an overlay here between the timely access laws that we have and the benchmark here, and use this benchmark as a way to drive compliance with timely access.
Yeah, it's a great point on the timely access, Ian. So I agree. There's, continue to be challenges. We know our sibling departments, including DMHC and DHS, continue to work on timely access. And I do think increased investment should assist with that. And we are in active conversations with all the sibling departments. And Don wants to add.
Yeah, the other thing that could happen is you have static supply, and we ultimately move to an environment where we have we've identified spending thresholds. You're potentially going to create more supply challenges. You might also have the unintended consequence of driving up unit price. So I think that's one that really needs to be monitored, and I would worry about
that. Thanks, Margaret and Debbie. I am supportive of some delay. I'm not sure about 3 years, and I guess part of the question is whether the ultimate measurement should rely on the information that OCA will be collecting from the plans as opposed to relying on HPD data. And it's not clear to me why. I gather the 3-year delay is, well, you haven't actually collected, the data submission guide hasn't been changed. You haven't collected any data from the plans. It's going to take a while. And if we need that data, then, a long delay, may well be necessary. But if the HPD data can be used, at least other than, big other than the question of all the Medi-Cal county level spending, where you clearly need to get that, but that's going to be not from the plans anyway, so that's a sort of separate work stream, if a very important one. If the HPD data can be used, then I'm not sure why a 3-year delay is needed as opposed to maybe another 1-year delay to do more analysis of the data that are in the HPD, and finding some way to put proxy spending on the encounter data where there's no spending data. I mean, I'm to Ian's concern, sort of figuring out what fraction of capitation is going to behavioral health or substance abuse services is always going to be, difficult. And so, collecting the data directly from the plans has got advantages in some ways, but, it's still going to be hard. And I can imagine you'd be better off, just kind of estimating what the spending is on the encounters that don't have any spending data associated with them, rather than trying to get it through other mechanisms.
I mean, I think that's definitely a consideration. The reason that we are emphasizing collecting data from the plans first is one, the claims data, the non-claims data, as you mentioned. So beyond capitation, any other non-claims data that support behavioral health, we would include that spending or a portion of that spending as it relates to behavioral health providers or behavioral health services. So could be things like infrastructure payments and pay for performance payments for behavioral health providers. So that may be a small portion or a very small portion of behavioral health spending, but we would be able to collect that data as well from the payers in addition to behavioral health spending under capitation. But it could be a potential option to use the HBD to further analyze data and to come back with a recommendation sooner than collecting data directly from the plans. I don't know if Vishal.
In the baseline report, it looks like the non-capitation part of the non-claims payment is really small overall, and I'm sure is very small in behavioral health as well. That doesn't seem like a strong reason to go to the plans rather than the HPD. Yeah,
well, and I think it's that data and using the plan's own analysis of their spending under capitation by using the methodology that we set, rather than us looking at encounter data only in the HPD.
Yeah, I mean, I would think that there'll be more uniformity if you do it through the HPD. The plans doing it themselves, there'll be more kind of differences across plans and what they're counting, even if you give them good instructions. And I can see a lot of advantages to using the HPD, including being able to move forward sometime before 3 years from now.
So I'll just appreciate how hard it is to do this. So I suspect your attenuated timeline reflects that somewhat. With that said, I would strongly recommend that we get at specialty mental health sooner rather than later. There's a lot of expenses that are in that population. That population is particularly ill, and they have a lot of physical health conditions as well as mental health conditions. So I know it's complex to hear from 58 different counties, but I would really try to accelerate that, because I think that will be a very important input to this data. And then maybe related to that, given that there are so many behavioral health reforms underway, it might be helpful, Marguerite, to summarize those, what the dollars are that are going into those programs, what the expectations are for those, just so we have the whole scan of what's changing even while you're trying to establish these benchmarks and benchmark changes over time.
Just a second to that last comment on the behavioral health transformation that you referenced earlier in the slides. And I think to some of the comments that Don made earlier too related to capacity, right, we're in real time, right? The changes are happening. So just really being able to see that, not necessarily opining on the date in which we're setting the benchmark, but really being able to understand those changes in the overall landscape and capacity, I think is going to be important. You referenced Massachusetts earlier, and you referenced also in the slide that this is a place where not in the same way that primary care had other examples, we don't really have that. Just refresh us one more time on what do we know about other states at all in this space?
In terms of their behavioral health benchmarks? Sure. So Massachusetts does not have a behavioral health spending or investment benchmark, but they do monitor behavioral health spending, as we showed earlier. The only other state that we know of that has a behavioral health investment benchmark is Rhode Island. And they have set their benchmark, and I might have to go back and look at the details, but to essentially increase from 200% of baseline over a period of 3 years. And I believe the baseline is set on 2022, but Debbie can correct me.
You got it right. So yeah, Rhode Island has a benchmark that they expect plans to increase their spending for children, outpatient mental health and all behavioral health, I guess, for kids up to age 18. Between 2022 and 2025. So this is the final year of the measurement, and so we don't have any reporting on the results.
Okay, thank you again for all of this work. So given that feedback and dialogue, when are you suggesting, this is an informational item, are you just verifying, are you asking in the future what our next step is in terms of the discussion of making the determination? Is there an action that you're going to ask of the board?
No action item anytime soon, but we definitely can't set a benchmark this summer. We could take the next year to see how far we get, including using the HPD, and kind of take it, 1 year at a time. And then, the plan that Margaretta presented was, assuming we don't get any greater clarity next year, then we would essentially collect the data from the payers and then continue to collect the data and then analyze it and then set a benchmark in spring of 2028.
Is there any milestone or any other next step by which we would need to make the determination to go earlier? May I ask it that way?
Yeah, you continued kind of feedback from the board, and we'll definitely take stock of that, and then if we revisit our thinking and we could accelerate it, we would come back with an alternative.
Yeah, when the staff was talking about options, we did talk about potentially putting it off next year to 2026, and just really wondered if we would be ready in 2026, which is why the 2028. But I hear the feedback about the data sources that would be best, and so I think we can commit to coming back, at least touching base with the board and sharing the information that we have next year, and seeing what the board may want to do at that point. Is that fair?
Yes.
Did I hear you say that Rhode Island in 2025 would have the results of their benchmark? This is the 3rd year of their survey?
I think
It'll probably take them some time to get the results because of the claims run out period. So I'm assuming towards the end of 2026 at the earliest, or early 2027, they would know.
Yeah, we can keep track of the Rhode Island timeline and come back to the board with more details. We, just as summarized on this slide 84, the proposed next steps under the current proposal would be to really focus on finalizing the definition of behavioral health spending and moving forward with collecting behavioral health spending from commercial Medicare Advantage and Medi-Cal managed care plans, while also continuing to work with DHCS. And then if the board's preference is for us to really dive into the HBD analysis and come back to that as soon as feasible, we can focus on that as we are also collecting data from the payers through the OCA data collection mechanisms.
Are you planning on going back and trying to figure out the differential between the percentages at CalPERS and covered and HPD? Because that's odd to me. I think I have a hypothesis about the CalPERS HPD difference, which is that CalPERS is a more generous benefit, and so it may reflect a smaller percentage of total spend. But that does not hold for covered, and covered is the lowest of the three, I believe. So it just doesn't make any sense, and that, I mean, that's somewhat worrying if we're going to be using. I mean, we're going to be coming up with a number, and the numbers are right now kind of all over the place.
And Margaret, are the definitions being used in those three instances the same, the definition?
We all used the same specifications. I think we didn't sit hand in hand with Cover California or the CalPERS teams as they implemented the specifications, so there could be differences potentially, but the intention was to use the same definition. But we are interested in working with the CalPERS and Cover California teams further to really understand, what are the differences and trends across the three data sources.
And it seems like the fraction of visits that are covered by capitation could easily vary across the payers. It could be. It also could be some differences in the health status of folks. I mean, I would think Cover California probably worse health status, but maybe also worse access to care and kind of stigma. So those differences don't seem so big or surprising to me. Yeah, I mean, it'd be good to dig further, but I don't look at those and say, oh, there's something really wrong here. But I do think, and Margaret, I think you sort of asked the board, and I'm the only board member who said anything. I at least would support, going further with the HBD analysis. At least trying to figure out what this looks like for Medicare Advantage and for Medi-Cal using HBD, and trying to investigate the feasibility of putting proxy spending on the encounters, which to me doesn't seem like such a hard problem, but I'm not actually doing it, so easy for me to say. I would, though, also, I mean, I think that Sandra's point of, following the specialty mental health services, and as difficult as it is, trying to deal with the Medi-Cal county spending, I mean, that's clearly crucial here.
In terms of the proxy spending, I mean, we have to do that in order to get at the capitation, and capitation is huge. I mean, Kaiser, I forget what, it's a huge percent, especially in the north of Kaiser, and I'm sure other plans. The one flag, what really distinguishes this from other categories of care, where in, looking at the hospital sector, we were talking about 250% of Medicare as the norm, and much higher in many cases. Here, the norm in commercial is around 90% of Medicare. And so to the unit price, we might actually have to drive unit price if we're going to fix the labor market problem. But when we're setting that proxy, we have to balance against that, and obviously there's going to be huge variation across payers, and probably across geographies too, and different patient groupings and demographics.
Well, thank you, as always, for a robust discussion. Thank you for all the work on this, and thank the advisory committee also for your continued input and engagement as we work through this. And with that, we will open it up to public comment.
We'll now take public comment on this agenda item and also general public comment. Looking virtually, seeing no hands raised, we'll go to the podium.
Beth Capel for Health Access California. I was one of the work group members that encouraged the team to consider not setting a benchmark. And we did that for a couple of reasons. It wasn't just me, more than one of us. After sitting through the discussions for a year now, longer, monthly, and the board members have identified this, what is included, whether it's the HPD or the THCE, in what the plans cover is a subset of the mental health care that people get. By the time you look at, and we have no idea of the scale of county behavioral health and the other carved off Medi-Cal services. We have no idea of the scale of out-of-pocket spending, except we know they're substantial. And there's another huge gap that I'm forgetting at the moment. The correction system. When you look at the provision, too many people, their first intersection with behavioral health is either in jail or in the emergency room. It's just too big. And so we literally could not, on primary care, we got there really fast. On this, we literally could not figure out what should be the target and why. And so at that point, the recommendation has to be, we don't know enough to set a target. I will also say, and the board discussion is reflected in this, we are in the midst of a transformation as a result of this administration, the Newsom administration, and how we do behavioral health in the state. It is not just Medi-Cal. It is also what's been done in the commercial space with SB 855 and other changes. And so we're in the midst of this transformation. We didn't want to set a benchmark that artificially drove demand, supply, policy focus in the wrong direction. So it seemed better to wait and get more information. And so that was the conclusion that you now see distilled in a much more elegant way than what was in the work group, because work groups are work groups. But that was why we suggested that it was premature. 2028 came as a bit of a surprise to me, but that seems a bit far off, but it may be that it takes more time and more, and the lack of other states having sorted this out and how different California is. When I look at Mass Health, I don't know if they carve off all the stuff in Medicaid that we carve off and have since Ronald Reagan closed the state hospitals. Darned if I know. But you need to answer all those questions before you can determine what's comparable and what's not. And we haven't answered them yet. So we don't like supporting not making a decision, but I think that's what we support here. Thank you.
Thank you. Looking virtually, seeing no hands, back to the podium.
Good afternoon, Jenny Nguyen with the California Hospital Association. We look forward to engaging and providing feedback on the behavioral health investment benchmark. We've shared this before, but want to lift up again our request that OCA include claims for residential and inpatient mental health and substance abuse disorder treatment in the benchmark. The nationally recognized model for a modern continuum of behavioral health care includes treatment available at all levels of need, from outpatient to residential and inpatient care. We have strong concerns that only including outpatient care in the benchmark ignores evidence-based treatment models and the need to ensure growth and access to care throughout the entire continuum. We do not have concerns with setting the benchmark at a delayed timeline, but just want to flag that this will affect the spending target measurement as it relates to promoting investment in behavioral health, and that this will need to be recognized. Thank you.
Thank you. Looking virtually, seeing no hands raised. Noting for the record, we have about 100 virtual attendees at this point. Seeing no one at the podium, noting this was also the general public comment period, I believe that concludes public comment.
Okay. Wonderful. Thank you again for the work on that last item and all of the items of our conversation today. Very much appreciate everyone's engagement in this continued work together. We will see you all again on July 22nd, same place at 10 a.m. And again, appreciate all of the input and engagement today. Meeting adjourned. Thank you.